Let's see. Hello, YouTube. Are we live on Facebook? Let's see. Looks like it. Hello, my friends. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, February 16th of 2025. I don't know about you, but time seems to be moving quite rapidly right now. That's how it feels to me. I can't believe it's 2025. Anyway, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am an IC support group leader, and on many Sundays, if not most Sundays, I come online. Hello, Debbie, and try to offer a live IC support group meeting for patients who are homebound, patients who don't have a support group near them, and patients who are looking for really good factual information. Because right now, the IC world is being rather tormented by a lot of misinformation online. And so my goal in doing these meetings is to give you the best information that we can find that's based on years of study, years and years and years of IC study. Now, I am simulcasting right now. So I am simulcasting when I look this way. I'm looking at Facebook. When I'm looking over here, I'm looking at YouTube. You're on two different internets. Facebook, you're on AT&T. YouTube, you're on Comcast. Because I am out in a rural area and I don't have fiber. And so I have to use two different DSL lines to live stream. So we'll see. They did offer me fiber for $700 a month. It's like, yeah, no. That's not going to happen. That's not going to happen. Okay, so you guys. Number one, I hope you're having a great day. I hope you're feeling well. I hope your IC's under control. Your pelvic pain is improving just a little bit. Some of you might be flaring. I flared yesterday. I was having a pelvic floor flare yesterday. Very annoying. It's in a bladder wall flare. It's a pelvic floor flare from driving. And literally, as I'm sitting here right now, my left butt cheek is vibrating because I have a pudendal neuralgia on my left side. So I woke up at 4 a.m. with my left hip vibrating. And that's from pressure on the nerve. And that relates to a really old pelvic floor injury that I have. Thank you, Dania. Ann says, did you hear about the oxybutynin gel for OAB? I did. I don't have a lot of information on that right now. It relates to what we're going to talk about today, though. Okay. So when I do these meetings, generally what I do is a little 30-minute intro on something educational, and then I will take your questions. Some meetings we go for 2 hours. Some meetings we go for 90 minutes. Other meetings we go for 5 hours. I think the longest meeting I ever did was 6 hours. So I'm here for you. As long as we're good, we're good. When you're done with your questions, that's fine too, because it's a beautiful Sunday and we have lots of other things that we can do on Sundays too. So hello, YouTube, you guys. You're being a little quiet. Say hi on YouTube. I see you. You know, it's interesting. You see on the back wall here, we have our book IC 101. It's not just a bladder disease. And when we released that 2.5 years ago, it was really cutting edge. First book to talk about phenotyping and all these new things. And I was going through it this morning. Boy, God, I have to update this, and I got to update this, and I got to update this. So I'm going to be doing a lot of updating this spring for our second edition for our book IC 101. Today, we're going to talk about bladder treatments and bladder instillations. What do they do, and do they work? And I'm going to start with the story of two patients. Patient number one, her very first appointment at the urologist for a referral for IC, she was seeing the nurse practitioner. The nurse practitioner said, hey, we'd like to take a urine sample. She said, fine. They were doing what we call a clean catch urine sample, where they were doing it through a catheter. So, you know, she puts on the gown, takes off her clothes, lays on the table. The nurse practitioner pulls out urine with a catheter and then gave her a bladder installation for which she had no clue. Literally at the very first appointment, before even talking to the doctor, somebody put a medication in her bladder. They did not give her informed consent. They did not tell her what it did. The only thing she knew is it hurt like hell. And so imagine she's laying on the table, she's in the stirrups, she's going, "What did you just do? Ow, that hurts. What did you just do?" And the nurse is like, "What's wrong? I just gave you a bladder instill." And she's like, "Wait, you put a treatment in my bladder and you didn't even tell me what it was? Outrageous. You never, ever, ever let anybody put anything in your bladder without telling you what it is, what it's supposed to do, and what are the risks. Like rule number one. And the problem is, again, especially if we go back pre-phenotyping days, go back 10, 15 years, the thing is you're so desperate to feel better, you'll let anybody do anything to you. I can't tell you the number of patients where they've said, "I've done everything." I'm like, "Okay, tell me what you do. What treatment did you do?" They go, "I don't know." Wait, you had a bladder treatment and you don't know what the treatment is? What they put in your bladder? I don't know. Guys, unacceptable. Unacceptable. This is the era now of informed consent. You never, ever, ever let anybody put anything in your bladder without telling you what it is. I encouraged her to file a complaint with the nursing board and certainly with the doctor of the clinic. That was outrageous. The other thing we have to deal with here is that a lot has changed in the IC world. We have old treatments from decades ago that we don't do anymore. Bladder strippers, silver nitrate, chlorpactin, perfect examples of what we call a stripping medication. The theory back then was there was something fundamentally wrong with the bladder wall. Therefore, if you just strip it off, a new whole bladder wall will grow. And I think that they were doing that under the assumption that maybe IC patients had a weird bladder disease in their bladder wall. Therefore, if you strip it off and you get rid of the disease, et cetera, et cetera. Well, now we know the utter foolishness of that approach. If you have a wounded bladder, why would you strip it and make it bigger? I mean, like literally, why would you do that? So the second patient I want to tell you about is a patient who was in Texas who was the wife of an active duty soldier. So she was getting treatment through TRICARE, diagnosed with interstitial cystitis. They admitted her to the hospital. The first day, they gave her an hours-long infusion of silver nitrate at like 10%. Silver nitrate is a bladder stripper. The second day, they gave her hours of like a 20% instillation of silver nitrate. The third day it was up to like 30 or 40%. I don't actually remember the exact dosage, but they increased the dose. They increased the stripping power. And her husband called me on the third day crying, "What do I do? What do I do?" My wife's screaming in pain. And I'm like, "What'd they do?" "They're giving her silver nitrate." "What? We stopped doing silver nitrate 25 years ago. We don't do silver nitrate anymore. What are they doing?" And they said, "Well, that's how they treat IC." And I went, "Not in any guideline. Silver nitrate is specifically excluded as a treatment." Imagine the damage that that did to her and her family, physically, mentally, and emotionally. Like literally, she's awake and they're putting a stripper in her bladder for hours and hours and hours. Pamela says, "A doctor put me in outpatient, said I would smell." Oh, yeah, hon, that's a different one. We'll talk about that. So the mistake that this couple made is that they did not walk into the doctor's office having done their education and having read about IC and bladder treatments. Because our guidelines are very clear. Silver nitrate and fluorpactin are no longer they're not even discussed as IC treatments. No longer discussed. So let's go through what a bladder installation is and what it's meant to do. And guys, give me one sec. I hear a little alarm. Hold on. I'll be right back. Hold on. Okay, sorry. That was just a timer going off. Okay. So, what is a bladder treatment? What is a bladder installation? A bladder installation is when you put a medication directly into the bladder. You use a catheter. There are a bunch of different medications that they can use, but the concept behind a bladder installation is that you're delivering the medication exactly where you need it. Exactly where you need it. Okay. And sorry, I'm trying to adjust my cameras here. My camera's being weird. So ponder for a moment the only oral approved medication for IC, Elmeron. One of the reasons why Elmeron was developed was because bladder installations are annoying. Bladder installations require you to go to the doctor. Bladder installations require you to have a catheter. Bladder installations require lots of visits to the doctor if you're during a course of treatment. They're annoying. They're frustrating. Wouldn't it be easier to just take a pill? Well, of course it would be. Of course, the problem with that is digestion. And that is, for example, with Elmeron, which acts as a bladder coating, it has basically a 92-93% bioavailability. What does that mean? Well, actually, 92 to 93% of Elmeron is destroyed by digestion. So it's like it's like a 5 to 8% bioavailability. That 92 to 93% is actually destroyed by digestion. And so literally one of the most ineffective ways that you can take a bladder treatment is by mouth. Because how much of the medication is actually going to arrive in your bladder and be helpful? Right? Not very much. So the advantage of a bladder installation is it delivers the medication exactly where you need it. 100% of the medication arrives exactly where you need it, directly into the bladder. Makes sense. Now, there are some things that are commonalities that happen with bladder installations. Number one of the reasons why bladder installations are so annoying is the urethra gets really, really irritated. Like the first couple of times you pee, anytime you have a bladder installation, your urethra is probably going to scream at you because your urethra does not like being stretched. And so, how they do the catheterization is important. The catheter they use is important because generally we use smaller catheters. We use slippery catheters that we call low friction catheters that slide in and out really easily and they minimize trauma to the bladder wall. Okay, so a low frit catheter is the way to go, pediatric size usually. That helped tremendously. We're kind of way past the days of the big, thick red rubber catheters that are known to be a bit more irritating. Now we go for the smooth, small, slippery catheter, in and out, super, super easy. Then we have something called dwell time. And dwell time is how long does the medication, how long are you supposed to hold it in your bladder? Because the challenge here is that whatever you put in your bladder, you're going to pee out eventually. And so we have a concept called dwell time, which is how long should that medication be held in there? And generally in the IC world, the dwell time is like 15 to 20, 30 minutes. Back in the old days, people said the longer you hold it, the better. But if you look at our guidelines and you look at a lot of the research out there, really, we're looking at a 15 to 20-minute dwell time. And there's an important rule here. And the important rule here is do not try to drive home with a bladder treatment in your bladder. I did that. I did that with Elmeron. Please don't do that. You will pay a price. It is always better to complete the entire treatment, sit there with a book or your phone for 20, 30 minutes, go to the bathroom, and then drive home. Okay? Trust me. The last thing you want to do is get stuck in the in traffic when you got a painful bladder installation in there. And again, it depends upon what installation they do. Right? There are different installations. So, who are bladder installations going to be the most helpful for? Well, a bladder installation is kind of what I call chasing the symptoms. So, for example, the most popular installation that's used around the world right now is called a rescue installation because it can rescue you out of a painful flare. And so a rescue installation is going to have a nerve numbing ingredient in it, like lidocaine or marcaine, and it's going to have a coating in it, like heparin or Elmeron, to kind of coat your bladder. Darn it, there was something else I was going to say there. It just went in and out of my brain really quickly. Sorry about that. So if you're in a flare, a rescue installation is great. And some doctors, like Curtis Nickel, before he retired up in Canada, had a rescue installation day, usually on Fridays, for patients who were flaring. The best case scenario is if you're really struggling with a terrible bladder wall flare and you're peeing every 15 minutes and you're following the diet and infection has been ruled out and your nerves are just really malfunctioning down there. Azo isn't working. You can ask for a rescue. And hopefully you will walk out of that appointment for 3 or 4 hours without any pain. I am of the position, though, that rescue installations and installations in general are falling out of favor now that we're phenotyping. So go back with me 20 years ago, okay, or 30 years ago when I was diagnosed. Back then, we all assumed that this was an incurable bladder disease. We didn't know anything about phenotypes, the pelvic floor, anything at all like that. And treatments focused on bladder installations, Elmeron, and antidepressants, and diet modification. That was it. The challenge is, like for me, I did a bunch of bladder installations. They never worked for me. Never. Never. Why? I mean, I could have had a bladder installation every month for years. They simply did not work for me because my phenotype is pelvic floor. I am a pelvic floor driven patient. And remember, we now believe that 85% of IC patients are neuromuscular in origin. So I think about all that discomfort, all that money lost, all that time doing bladder installations, which had no chance in helping me at all. Because my IC was never caused by my bladder wall. I've always had a healthy bladder wall. My symptoms are being driven by a tight, injured pelvic floor along with a very sensitive nervous system. And so today, when a patient is diagnosed with IC and we're trying to find underlying causation, we always want a phenotype because your phenotype determines your treatment approach. So if you, for example, have Hunner's lesions, Let's say you have a Hunner's lesion from a viral infection. Is a rescue installation going to help the underlying cause? Is it going to kill the virus that's causing your lesion? No, of course not. Would a rescue installation give you a little bit of comfort? Yes. But you always have to understand that your goal has to be to try to fix the underlying problem. And a bladder installation does not fix or repair a Hunner's lesion. At least I'm not aware of any research that shows that. Okay. If you are bladder wall driven chemocystitis, that you've got a chemical injury of your bladder because you've gone through chemotherapy or you were drinking a lot of diet soda, some sort of chemical ketamine has damaged your bladder wall, is a rescue installation going to help you? Well, it's not going to fix the underlying problem. What's going to fix the underlying problem is getting rid of the chemical that's irritating your bladder so badly and giving your bladder time to heal. But it might help ease some of your symptoms for the short term, but it doesn't repair anything. Only your bladder can repair itself. Okay, so let's go to estrogen atrophy. That sizable group of patients whose symptoms are being caused because their estrogen levels have dropped. Of course, this is really just for women. Of course it is. Okay, so your bladder has become super sensitive because you don't have a lot of gag in there. You don't have a lot of mucus anymore because your bladder needs estrogen to produce mucus. But you're older, you don't produce the estrogen anymore. So your tissues are getting drier and drier. Dry mouth hurts, dry bladder hurts, dry urethra hurts, dry vagina hurts, etc. Will a bladder installation fix that? No, of course not. What a bladder installation will do, it might calm some of the nerves down, but your job has to be to improve the quality and health of your skin because your skin is dry. And that's where we're going to do things like topical estrogen or maybe gag layer replacements. Now, the exception to that would be, let's just say, now this is, I've had a couple of patients say this to me over many, many years. They will have a hydrodistension. The doctor will look in bladder and say their gag layer is gone completely. They have no mucosal layer in their bladder. Their bladder wall is just open to urine getting directly onto the cells, directly onto the nerves. That would be extreme, extreme, extreme estrogen atrophy. So in that context, would a rescue installation help? Maybe yes, the heparin might coat their bladder wall, give them a little bit of extra protection. The lidocaine would calm the nerves down. So I think for the severe estrogen atrophy patient, there's a real good role for rescues over time until we can get enough estrogen in there for your bladder to start replacing its mucus on its own. If we go to our third phenotype, which is pelvic floor driven, so your symptoms are being driven by super tight pelvic floor muscles and ischemia or ischemia, is a rescue installation, bladder installation going to fix that? Hell no, of course not. Is it worth paying $200, $300 for a bladder installation for a short-term gain, turning off your symptoms for a day? Or is it worth putting that money into physical therapy, which can actually fix the underlying problem so you don't have symptoms? Is a bladder installation going to help pudendal neuralgia, pain when you sit down that gets better when you stand up? Of course not, because that's all about muscles and nerves. Is a bladder installation going to help widespread pain, patients with IC, IBS, vulvodynia, TMJ, etc.? Well, patients with widespread pain have a super, super sensitive nervous system, an injured central nervous system, usually from a history of trauma, physical trauma or emotional trauma. And so for these patients, yes, we're going to calm things down. So it might be a way of calming the nerves in the bladder down for the short term, but it's not going to fix the underlying problem because the underlying problem is something very, very different. We have to work on the central nervous system, not just the nerves in the bladder. So I hope that you can see now that it is important that you think about underlying causation. What are we trying to treat? what's driving your symptoms, and then asking yourself, will this treatment address the underlying problem? Some patients out there have had dozens and dozens and dozens of bladder installations. They go back, they're always getting bladder installations. My answer is, well, clearly they're not working if you have to go back every week. Clearly they must not be working. And they're like, oh, good point. Good point. And what we don't want to do, what our AUA guidelines are very clear about, is if you're not responding to therapy, if you're getting worse rather than better, take a step back and revisit the diagnosis. We don't want to continue to do treatments that aren't working. And that's hard when a rescue installation, for example, gives you 3 hours or 4 hours without pain. You're thinking, ooh, that's a good thing. And it is a good thing. We don't want you suffering. But you still have to be focused on what the underlying cause could be too. Don't chase the symptoms. We want to be laser focused on trying to identify underlying causation. So what are the types of installations that are out there? Well, I've been talking about rescues. So again, a rescue is by far the most popular treatment done around the world as a bladder treatment. It's going to have lidocaine in it or marcaine in it to numb nerves. It's going to have heparin in it or chondroitin in it or hyaluronate in it to coat the bladder and provide a protective coating to the bladder wall. There are some installations that just do the coating. They don't do anything else. And so here's one study here of just heparin. At 3 months, 56% of patients reported significant improvement. You can do a combination of hyaluronic acid and chondroitin. Hyaluronic acid is naturally found in the bladder mucus where it helps to protect the underlying tissue. It is believed to bind lymphocytes and endothelial cells where it blocks ICAM receptors and alleviates inflammation. Clinical trials show modest success in reducing the symptoms of IC in Europe, but not in the United States. It did not meet the standards for FDA approval. Their IC studies were found to be lacking. You could do a straight chondroitin installation. Again, protective layer in the bladder. Of course, the challenge is that that's not available in the United States as an installation, but it is available in Europe. And it's funny, there was a company that was a BioNiche that did Cystostat, which was hyaluronic acid, and then there was another company that did Uracyst, which was chondroitin. And these two companies were duking it out about 20 years ago. My installation is better. My installation is better. And they were all publishing lots of different studies, and neither one was profoundly successful until somebody geniusly added them together. And it turns out that an Ialaril installation, which is a combination of chondroitin and heparin, or chondroitin and hyaluronic acid, was much more successful. So if you're in Canada or Europe, you could do an Ialaril infection. Again, like for estrogen atrophy, that makes sense. You could try an Elmeron installation, a combination of Elmeron and lidocaine. Now, remember, Elmeron, when taken by mouth, is associated with retinal disease and eye disease and inflammatory bowel disease. But when you put it directly in the bladder, 100% of the medication arrives in the bladder. And it's not believed to any great degree to get into the circulatory system where it could potentially get to the retinas, but I don't think we have any research that validates that. But some doctors converted patients from oral Elmeron to Elmeron installation. The other challenge here is that doctors have their own formulas. And so there's not a lot of consistency across the bunch. So, for example, Christine Whitmore was one of the first. It's called the Whitmore heparin cocktail. Chris Payne had the Payne heparin cocktail. Dr. Bade in Europe had the pentosan polysulfate cocktail. Dr. Parsons had the heparin and alkalinized lidocaine one. So I have got all of those formulas over on the IC Network website if you're interested in looking at that. But again, remember, a lot of this was done before we started phenotyping. And now we more clearly understand just how and why an installation doesn't make sense for a lot of patients. But for some of you, it might. So let's talk about DMSO. DMSO, the brand name is Rimso 50, is the only approved bladder installation for IC by the US FDA. It was approved in the early 1970s. Now, DMSO is interesting. DMSO is a byproduct of the wood pulp paper industry. Go figure. So when they're making paper, there's like byproducts from that process that somehow they extracted DMSO in some way. DMSO was first discovered and identified in the 1950s or 1960s when they were looking for ways to move kidneys for transplant from one hospital to the other. Because you can't freeze kidneys because the ice crystals will destroy the kidney. And so there was a great attempt back then to figure out ways to safely transport organs for transplant. And somebody found the DMSO, and it turned out it worked. DMSO back then was really thought to be a wonder drug. And so they made a lot of claims back in the 60s that DMSO would do this and that and this and that. And they made a lot of claims with a lot of diseases. All of that research failed. The only study which showed modest success was an IC DMSO study. But I think today, if that study were done today, it probably would not be given any credibility. It probably would not have led. I think they would have had a lot more robust questions about the method of action of DMSO if they tried to get it approved today. But anyway, it was approved back in the early 1970s. It is essentially a diluted, sterile, and purified version of an industrial solvent found to have anti-inflammatory, analgesic, muscle relaxant, mast cell stimulation, and collagen dissolution properties. Patients generally would have 6 to 8 weekly treatment. They would hold it for roughly 15 to 20 minutes. If improvement was found, a second course of treatment might be suggested. But DMSO is rarely used as a long-term therapy, nor should it be used if patients show no response to treatment. There have been many research studies with DMSO. Some have shown minimal treatment, some have shown great success. However, adverse events, mild adverse events are common. I had 8 DMSO treatments. I will tell you that they were very uncomfortable and they did nothing for me. But of course, now we know why they did nothing for me, because I was never bladder wall driven. Again, it's just a complete waste of money. The second issue that we have with DMSO is dosing. So if you look at the research with DMSO, there are so many methods of action happening. It does so many different things that it's really unclear how it actually helps the IC patient. One theory is that it provokes all the mast cells to release at once, thus basically draining them or emptying them, but that's not depleting them. And that it takes weeks for them to become normal again. That was one old theory I remember hearing years and years ago. One thing that DMSO is very good at is it's a good penetrant. It gets through tissue. I mean, because that's the other problem with the bladder. I mean, guys, you got to understand the bladder wall is a beast. The bladder wall is built to keep things out, to keep things contained. So your bladder is like a balloon that gets bigger and smaller and bigger and smaller. And there's a really thick coating of mucus inside there that acts as a barrier. And that mucus is hydrophobic, it pushes stuff away. And so the mucosal layer pushes medications away from the bladder. So it's a real challenge to get medication across the mucosal layer into the bladder where it can do some good. That's why they put sodium bicarbonate in a rescue installation, is if you alkalinize it, it crosses the barrier a little bit better. But DMSO happens to be a very good penetrant. So DMSO can carry molecules through the bladder wall and deeper into the tissue. But again, we're still quite unclear as what it actually does. And so back in the 1990s, 2002, 2003, there was a young IC researcher named C. Suba Packer. And I think she was at the University of Kansas or Iowa. And she wanted to try to understand a little bit more about what does DMSO do and how does DMSO affect the bladder directly. And so she was studying dilutions of DMSO on rabbit bladders. Okay, because that's animal research, guys. That's why I left pharmacology, is I could not do research like that. But literally, they have to use animal tissue to do studies. And so she was, I'm not saying it was bad, I'm just saying I can't do it. I love animals. Even though I've got a degree in that, I couldn't go in that direction. Well, here's what she found. She found that the FDA-approved dosage of 50% caused the bladder smooth muscle to contract, in some cases permanently. That the human dose suggested by the FDA made the bladder go like that. Irreversible bladder spasm. And she was quite concerned about that. So she presented her information to the AUA, American Urology Association. And I was at that meeting. It was in Los Angeles. I read the abstract before I got to the meeting because I knew I wanted to talk to all the IC experts about it. And so I walk into the meeting. You know, these meetings are like science fairs. They're literally posters on the wall. And doctors walk around and look at the posters and talk to the researchers standing in front of the poster. And so, I walked around, saw hers, said hi, looked at the data. I was stunned because I had had it done. Remember, I had had the FDA-approved dose of 50%. And then I went to the top IC doctors. And I went, so what do you think about the DMSO paper? And they were like, oh, we're not surprised. Some were like, yeah, it's early research. Maybe we need a little bit more information. Others were like, yeah, we thought that it was potentially doing something like that. Okay. I mean, because this was just blowing up this common treatment for IC back then. It was like, wait, what? DMSO could cause the bladder to have an irreversible spasm? That's a bad thing. So as part of this poster session at the American Urology Association, the researchers got to go up to the podium and share their research, which she did. And then the researchers and doctors in the audience could then ask questions. And I will never forget this moment because Dr. Ray Rackley at the Cleveland Clinic, who is one of the big top IC doctors back then, stood up and said, we don't use DMSO in our clinic, and we will never use it. We believe that the great majority of damage done to the bladder that eventually results in us needing to remove somebody's bladder is from DMSO. And that was a woo! Wait, what? And most of the doctors in the audience were like, yeah, we don't really use it that much either. There was one doctor from a big prominent facility who said, I think that there's a place for DMSO, but I don't give it to everybody. The general consensus at that meeting was Dr. Packer's research showed that 50% was damaging. So you would always use DMSO in a cocktail form with other ingredients. And when you add other ingredients like heparin and triamcinolone and sodium bicarbonate and whatever, you're reducing the dosage to roughly 25%. And Dr. Packer's research said that 25% was safe. It's just as the dosage increased, that's when the damage occurred. And so it was really at that moment in time that DMSO cocktails became the standard. It's interesting, though, that I still come across newly diagnosed patients who are getting DMSO treatments by urologists who don't do IC very much, who are basically treating IC out of an old textbook and giving them 50% DMSO. I personally know I'm not your doctor. I can't give you medical advice. That's not my job. I just don't see a place for DMSO now. I really don't. I don't understand which phenotype it would be the most helpful for. And I truly believe that its use has dropped around the world pretty significantly. It doesn't come up that often anymore in our office. Now, there's something else that you need to understand, and that is that DMSO is an industrial solvent. At full strength, it is harmful. And so what happened was, and this was probably 10 years ago, there were some compounding pharmacies that fell victim to a company in China selling DMSO on the down low cheap. And they got faxes about it. Hey, you want DMSO? We can send you DMSO. And so one office manager in a urology clinic bought it. And the little bottles looked just like the brand name. And she did not tell the urologist that she wasn't getting brand name. She went for the cheap one. And the first time he used it and he put it in somebody's bladder, it literally destroyed their bladder because it was full grade industrial solvent that had not been prepared for human use. It had not been diluted. And that's actually happened a couple of times now. And I can remember the representative that was selling Rimso 50, the brand name that you can trust. They were telling me about these cases. They were calling and letting the patient organizations know, please let your people know that we've got this problem right now with this highly damaging DMSO going into urology clinics. And so the take-home lesson for that is if you, for some reason you are doing DMSO, you need to make sure that you look at the bottle and make sure it says Rimso 50, RIMSO 50. Because that young girl, she was young, she was like in her 20s, had to have an emergency bladder removal after that DMSO installation. So remember how I started this meeting? You never, ever, ever let anybody put anything in your bladder without telling you what it is. What is it supposed to do? Why are you doing this? How is this going to help me? Is this safe? And if this is DMSO, is it brand name? Because we're not doing generic DMSO. No, sorry, Bob. Now, the bladder installations that are no longer done are going to be silver nitrate, like we started, chlorpactin, which is so interesting. Chlorpactin also was a very big treatment back when I was first diagnosed, and it was originally used to treat tuberculosis. So they brought that in to kill mysterious infection in the bladder, I think. Bacillus calmette-guerin, BCG, that is a treatment for bladder cancer. And they originally thought that that would be helpful for IC, but the research proved that it wasn't. And then there's one other bladder installation called racinoferatoxin, also known as RTX, that was also thought to be helpful for IC, but research proved that it was not helpful. So no silver nitrate, no chlorpactin, no RTX, and no BCG. They're specifically discouraged in our guidelines. So again, this is what I want to challenge you with, and that is that now that we're phenotyping, we have to create new roles for old treatments. We have to learn the lessons from the past. And the lesson from the past is that bladder installations never work for a bunch of people. Why? Because a bunch of people are being driven by pelvic floor problems as compared to a bladder wall issue. And so, gosh, who was that? I was working. Oh, you know what? I was working with a patient last week. What did she say to me? Oh gosh, what did she say? So she called because she just wasn't having success with her treatments. And then she started saying, I've done this and I've done this and I've done this and I've done this. And then I did this instill and then she said a bladder treatment. And I'm like, what bladder treatment? She didn't know. Um, and whenever people start leading off all these treatments, I go, stop, 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 stop. We're not starting there. It's pointless to talk about treatment until we understand your anatomy, your underlying anatomy. We need to figure out what your phenotype is first. We need to try to identify underlying causation. And depending upon which group you're in, your group determines the most successful treatment. So again, Hunner's lesions. Now we know Hunner's lesions are driven by viruses for some patients or by a damaged ligament. Will a rescue installation fix that? Absolutely not. It might make you feel better for a couple of hours, but it's not going to fix anything. Perfect example of chasing the symptom. And again, if you're in severe pain, I have no problem with you going having a rescue. If it'll help, why not? But don't get fooled into thinking this is fixing underlying problems. It's just making you feel better. We still have to fix underlying problems. So will it help with estrogen atrophy? Yeah, I think that having a little bit of extra coating in your bladder is not a bad thing while your bladder's healing, while you're doing the proper estrogen treatment and whatever treatments you're doing for that. Will it help with chemocystitis? Yeah, if your bladder wall's super, super irritated, it's going to cover that, it's going to coat the bladder nicely, give you a little bit of anesthetic. But ultimately, it's all about your bladder healing. We just need to help your bladder heal. Once your bladder heals, you might not need it anymore. Is it going to help with pelvic floor driven symptoms? If you're in a severe state of ischemia and your bladder wall screaming at you, it might help a little bit. Is it worth investing $5,000 in doing bladder installations? No, you need to invest that $5,000 working on your pelvic floor. Will it help with pudendal neuralgia? No. Will it help with widespread pain? No. It'll calm nerves down for a short term, but it doesn't fix anything in the long run. So that is my take on bladder installation. So my hair is being so weird today. I've got pop-up hairs everywhere. So let's take your questions. Janelle on YouTube says, is anybody having success with extra shockwave treatments? I have never talked with a patient who has had success with the shockwave treatment. I know that it's getting more and more popular. I'm just not there. I just don't, uh, I can't say that it's particularly helpful. We'd have to look at the research. Shemper says, thank you for covering bladder instills. Mine is pelvic floor driven, nerve pain, and food driven. All right. So what does that tell me? Your pelvic floor driven with food sensitivity. So that tells me you're in a state of ischemia. Your bladder's not getting enough blood supply because your muscles are so tight they're restricting blood flow. Will you have a healthy bladder if your bladder's only getting 50% of the blood it needs? Of course not. That's called ischemia or ischemia. Physical therapy is going to restore blood supply because it's going to relax and release those muscles. And as this new healthy supply of blood floods the bladder, it delivers the oxygen and nutrition your bladder needs to heal. That would be my best guess. So, would a bladder installation help for the short term? Yeah, for a flare, maybe. But long term, I don't see it being that valuable. And again, what do our guidelines say? If you're not responding to, listen, don't do bladder installations continually if you're still flaring. If you're still flaring, clearly they're not doing anything. It's a short-term benefit. It's not helping you over the long term, in my opinion. Diane says, I'm doing an elimination diet that's pretty restrictive. How long before I should expect my bladder symptoms to improve? How long do I wait before trying to introduce foods? Well, again, Diane, it's about your phenotype. That's what we need to know. So if you have food sensitivity because you have wounds in your bladder from Hunner's lesions, then you're going to be struggling. You know what? Sorry, guys. We've got a big storm coming in and the light's all weird. And let me see if I can improve that. There you go. That's a little bit better. California, big, giant rainstorm the last couple of days. It's been an adventure. Lots and lots of flooding and mudslides, even by my house. Diane says, she says it's mostly estrogen atrophy, which got much worse 2 years after menopause. You've been on estrogen cream for 2 years. Okay. So then that helps us understand why you're so food sensitive. So you're two phenotypes. You've got bladder wall-driven symptoms from estrogen atrophy, and you have tight muscles. That's the ultimate chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved. Kathy says, how can I make an appointment? Just call us. The phone number is right behind me. You can just call. Mondays are my day off. So you can start on Tuesday. I'm going to the dermatologist to get a spot taken off on Tuesday. So later in the afternoon. All right, let's come here to Facebook. Okay, now you guys on Facebook, this happens every time. Facebook doesn't let me scroll back and it bounces around. So if I miss it, don't take it personally. Just ask the question again. Debbie says, DMSO makes you smell like a clam left out in the sun. So true. I didn't mention that. DMSO can cause a garlic-like scent. And some family members get really, you might not smell it, but family members are like, what is that smell? And that smell can last for a day or two. Angie said DMSO was very painful for her. She hated it. She did 4 installations, never again. Yep. All right. I don't know if somebody's in here talking about IC as a horrible disease. Guys, IC is actually not a bladder disease for most of us. IC is a neuromuscular issue / injury. The only people that have a disease process are patients with Hunner's lesions or patients with UTI. Donna said, I started on Desert Harvest Aloe and doing well on it. Can I take Bladder Builder with that? Sure. Debbie says she loves these lives. Thank you so much. Debbie, some days I'm scattered and I don't rehearse. I just have my list of topics and I just go for it. So some days I nail it, and some days I'm a little scattered. Today I'm going to say I'm a little tiny bit scattered. Marie says, rheumatologist says Skyrizi is being looked at as a treatment for IC. Okay, so it's going to be interesting to see what phenotype they're using for that. Kathy said, I was diagnosed with IC on February 14th. This website was referred to by my provider. I'm grateful I landed here. Thank you, Jill, for this wonderful Kathy, girl, welcome, my friend. Welcome. You are not alone. You are absolutely not alone. There are 3 to 8 million, 1 to 4 million men. And the blessing here is you weren't diagnosed 30 years ago when I was, when we had nothing. Today, we know so much more about this. And the most important thing is phenotype. We have to try to identify underlying causation because we don't want you to waste 6 months or a year or 5 years or 10 years, or in some cases, 20 years doing a treatment that has no chance of helping. And that's what IC was like 30, 20, 10 years ago. Everybody was on basic bladder meds, but it just didn't work for most people. And now we know why. Because most of us actually have a problem with our muscles instead. And Kathy, the question that I would ask you, since you were diagnosed this month, is there any event that you associate with the onset of your symptoms? Like, had you been traveling? Had you fallen? Anything happened that you thought played a role in why your symptoms began? Cindy said I had DMSO in the 80s. It was not helpful. Exactly. Linda, thank you so much for the 20 stars. Sylviane says, wow, this information is so interesting, helpful, important. You're welcome, honey. Hi, Kayleen. Long time no see, girl. Pamela said, my doctors don't like to be questioned. Have gotten nasty to me, asking what they are doing to me. Hey, man, they can get as nasty as they want. It is your body. You pay them. They don't pay you. You are the boss. It is so incredibly important that you take command of your medical care. But the way you do that is by reading before you go. You got to be prepped. That's why I have our new video masterclass, because it talks about how to prepare for your first appointment. It talks about what to expect at the first appointment. You got to walk in knowledgeable, armed, and informed so that you understand the treatments, you understand the phenotype, so you can say, hey, doc, what do you think about this versus what do you think about that? You know, the harsh reality here is that there are fewer and fewer urologists specializing in IC. The power researchers from the early 2000s are retiring now. And that next generation of urologists, we hope we would find one that's passionate about it. There are less. And so basically our national IC experts are Robert Evans, who has not said he's going to retire. Rob Moldwin, I haven't talked to him recently, but he's of that age. Ken Peters up at Beaumont or Corewell Health in Detroit. And then we've got some younger ones like Elise Day. But the other thing that's happening is now that we recognize that so many patients are being driven by muscles and nerves, actually the dominant care provider is really no longer the urologist. It's the physical therapist, and in some cases, the gynecologist. You know, like I haven't been to my urologist in 20 years. 20 years, I think. This is crazy. But it's my OBGYN who ordered the physical therapy. Thank you, Dr. Bennett, now retired. Oh, and you know, isn't it annoying when you've got a really good doctor and they retire or they move? I had the best gynecologist ever. And he was my age. And you know, listen, you got to give props to anybody who's a doctor right now and working in healthcare, because the healthcare environment is just downright nasty. It's physically harmful to them because of COVID, and so many of them died and become very, very ill with COVID. But it's become very hostile from an insurance standpoint. It's become very hostile some of the better doctors who, were really, really good at IC and would spend an hour with patients at their first appointments, they're not allowed to do that anymore because their clinic says you need to make money. And the only way you're going to make money is if you see more patients. And so medical care right now is challenging in the United States. And it's, I mean, every country has their own barriers and own challenges. I mean, in Canada, for example, it can take a year or two to actually get referred and see a urologist. That sucks. In the United Kingdom, it's a bit different. In Europe, it's a bit different. One of the big challenges in Europe right now is, oh gosh, we just had our international meeting a couple months ago. God, what did they say? Oh God, the European groups they were really struggling. Oh. So, it is the patient group we're the ones that empower you. We're the ones that try to educate you, right? I mean, that's our job. Um, but we're also potentially a source of irritation to pharmaceutical companies. Some of them might not want you to know certain things. Because they're in it to make money. And so they don't necessarily want you to come in and say, so what are the long-term adverse events of this, right? And a really good example of that is the Elmeron eye issue, which is probably the most important story that I ever told. And I'm the person who educated the entire IC world about the retinal disease. None of the other IC groups went public. I'm the one who went public at great risk. But again, I believe in informed consent. I couldn't sit on that story for a year. I believe that you need to know the potential risks versus benefits of treatment. And that changed the face of the ICU world. And that was my decision. And it was a very, very serious decision. So that was a really good example of a patient group, fighting back. Well, apparently now that we have AI, we have a pharmaceutical company that's saying, we don't need patient groups anymore. We have AI. And so now they're not going to help patient groups in other countries because they can create their own mini IC rule that says what they wanted to say to you. Hey, do my treatment, it's safe. Not happy about that development. John says, is low intensity laser therapy helpful? I think that there's some early research that shows that it is. I'm just not that familiar with it. And Kathy's asking about that, the PEMF treatment. And again, Kathy, it's all about your phenotype. So if your symptoms are being driven by tight pelvic floor, would doing laser therapy be helpful? I just don't see it because it's a biomechanical problem. We got to improve mechanics. Angie says, how do I take Peora, which is palmitoyl ethanolamide, and wean off my pain meds? I need education on supplements. Can I take Peora and D-mannose together? Okay, so Angie, number one, if you're on a lot of pain meds, you have to work with your doctors because you can't just discontinue some of them. I mean, the Norco, you could potentially gradually reduce your dose, although you may, if you've been taking it for a long period of time, you may have some drug tolerance going on. The tricky one is the Lyrica, because Lyrica is a medication well known to cause what we call a discontinuation syndrome. The general theory of reducing meds is that you gradually reduce over a dosage over time. Excuse me. But with some meds, you can't do that. So You're on some complex medications that are going to require a good, hard discussion with your doctor about how you reduce that dose. The problem with Lyrica is if you go cold turkey, you might hallucinate for 6 months. That would be bad. That's an example of a discontinuation syndrome. So you have to do it the right way with medical guidance, okay? Gianna says, do they know what causes Hunner's lesions? We have 2 theories now supported with research studies. Theory number 1 is Hunner's lesions are caused by viral infections, specifically the Epstein-Barr or the polyoma virus. That research originally started in Europe, where they were testing the urine of patients with lesions as compared to the urine of patients without lesions. They were the ones who first saw viral traces and viral DNA. Multiple studies continue to find virus in Hunner's lesion patients. And we were all here, that came out when I was doing these meetings and we were talking about it, because what was so interesting is that the American IC researchers, specifically our National Institutes of Health, was suspiciously quiet for like 5 years. It's like, guys, what do you think about the viral data that's coming out of Europe? What we didn't know is that they were doing their own viral study and they confirmed it. They found Epstein-Barr or polyoma in 5% of IC patients. Roughly 5% of IC patients have Hunner's lesions. Now, I was reading something today. I was looking at the big AUA meeting, which is going to have the big class on ICs in April. And so I was looking at who was teaching the class this morning, and I was looking at what they were talking about. And apparently, the MAP Research Network, which was a 10-year project, so that's called the Multidisciplinary Approach to the Study of Pelvic Pain, and that was a very large federally funded group that studied IC and chronic prostatitis. It may be done. I mean, the language they used was as it comes to the end or as it comes to its close. Yikes. And we're all waiting to see what's going to happen to IC research under this administration. Because the best IC research by far has been done by the National Institutes of Health, and they've put millions of dollars into it. And they've had very, very important breakthroughs. And I just hope and pray that it will be continued. I am supposed to be participating in a Center for Disease Control grant for the next couple of years. It took me 25 years to get there, to be asked to be involved. They came to me and said, would you help us with the study? I'm like, absolutely. What can I do for you? It doesn't look good. We don't know. The grant was funded and approved. I mean, the grant was approved, but we don't know what's going to happen. And I'm going to be really angry if we lose our IC research in the federal government. Do not even get me started. Katie said, under new installations under develop, you listed Cytotec. Do you know of many success stories of this drug for Hunner's lesion patients? Let me look. Let me see if they published that data. Let us see. Doesn't look like anything's published. No. I'm going to have to pull that off the website. All right. Marie says, my bladder was damaged during a complete abdominal hysterectomy. He literally cut my bladder in. Oh my God, Marie. He literally cut my bladder in half. How to count? What? You had a catheter for 6 months with horrific bladder issues, threw me into this whole IC nightmare. Girl, as somebody who has also had a hysterectomy, woo, does that take my breath away. Wow. I hope that you I mean, that's how did that happen? I mean, obviously, that was a terrible surgical error. Now, I have worked with another patient whose bladder broke into 2 pieces, not an IC patient, but they had to, uh, uh, sew the bladder together, back up together, and it worked. But a catheter for 6 months? Holy moly, girl. What does your bladder look like now? Pamela says she's flooded, tornado warning yesterday, and woke up to snow. Yeah, it's been such a weird year. It's been very wet and very cold here too. Wendy says, "What do you take to help with your nervous system?" I do Peora, palmitoyl ethanolamide. We got fantastic research with PEA and IC. It came out in 2019. 87% of IC patients who use PEA reported improvement in their symptoms and their pain. PEA acts by calming their nervous system down. But there's nothing as good also as some really good mindfulness, really good anxiety management, CBT. We've got to get that brain out of fight or flight. Remember that if you're a widespread pain patient and you suffer with anxiety disorder, um, anxiety causes and fight or flight basically um, amplifies the pain throughout your body. It intensifies the pain throughout the body. And so we've got to get your brain out of fight or flight. We've got to reduce that anxiety to reduce the overall pain levels. And that's why you should never be offended if somebody says, "Hey, would you like to do, some cognitive therapy or some mindfulness or just a basic anxiety management class?" I mean, any good pain management program around the country, as soon as you say you have anxiety, we know that becomes part of the problem and that always intensifies pain. I mean, listen, I've had since my cancer surgery 7 months ago, my medical anxiety is woo, man, let me tell you. Um, it's not off the charts like it was when I was in my 30s. I'm not having panic attacks, but I'm it's fascinating how a cancer diagnosis and major surgery just it's a shock to your system, and of course you're going to develop more anxiety. Of course you will. And I could recognize it was interesting because I could feel my anxiety levels up pretty high, and I could feel the fact that my nervous system was definitely becoming more sensitive. And that's one of the reasons why I decided to find an expert in medical anxiety to help work me through this. I mean, life is hard right now for so many of us. And I think we all have. Debbie says she has anxiety worrying about the next flare. My anxiety was about pain. I literally took a class in anxiety management because I was afraid of the pain. I was afraid of the flare and I was afraid of going to the doctor and having things done to my body that would be painful. And so my anxiety is really about uh, going to the doctor. I hate it right now. I don't even want to open their freaking emails. And oh, I can give you for my followers, just so you know. So, I have been going through a bunch of heart testing because I had a really, really dangerous reaction to the COVID vaccine last fall, and it put me into AFib and chaos, heart chaos going on in Jill Osborne's body. Um, and my blood pressure got all bunky, my heart got all bunky. I went into AFib. They thought I was going to die, and they asked if I wanted to be revived. Yeah, you want to talk anxiety producing? That added to it all. So I had an echocardiogram. Good. I just got the results from my heart monitor that I wore for 2 weeks. Good. No AFib. And then it's like the little things. So you're waiting for all these big test results, right? And you're just praying, please, God, please, may my heart be okay. Please, please, please. And then you get the kit to test for blood in your stool, going, hey, it's time to do that once a year check to see if you have bowel cancer. And I literally got that like 2 weeks ago, going, God damn it, I cannot cope with anything else. Leave me alone. Right? Just leave me alone. And I did it and I sent it in, and I was just like, please, please, please. I don't need anything else happening, please. And I got the results for all three 2 nights ago, and I just cried for like 2 hours. It's just like, so I have one more. I want to do a stress test. I want to push my heart and let's see what happens. Debbie says that shit don't stop. No pun intended. So true. Oh, so true. Debbie says, me too. Janelle says, I hear you on doctors. Debbie says, I want to do the installation at home because I hate the doctor's office. The other thing that I have become very bad at right now is, like, I have no tolerance for I just have no tolerance for certain things. And um for people who are being mean to other people, and people who, are firing all the people that support the nuclear weapons program. I was like, hello. Oh, come on, please. And so I swear a lot right now. I just swear a lot. And hold on. Where is it? Okay. No, wait, that's not it. Hold on. All right. Where is this great book? I have this great pelvic pain book that talks about what happens to your brain when you. Oh, here it is. Is that it? Yeah. Here. Nope, that's not it. That's a poem. That's a poetry book. All right. Wait a second. Well, anyway, it turns out that when you curse, as long as you don't make it a big habit, you actually cause your brain to release something which helps. Anyway, darn it. I want to read this to you. Where is this book? What did I do with it? It's called When It Hurts Down There by Dr. Angie Storr. It's a fabulous book. Well, it's somewhere here. So if you do call me, and if things start getting a little wild and you're not being treated well, I will just say, do you mind if I curse? And if you say yes, then I won't curse. If you say no, but let it fly, I will let it fly. And said I was going to talk about oxybutynin gel. Okay, let's look at what the research said. I know that. All right. I wanted to go to the most recent study because I swear I stayed across my desk. Oh, what? Oh, that's weird. It's doing. Okay. You know what? I have to do this on this computer. Hold on. I got to switch computers to look to do this. Give me a quick moment. Okay, so the most recent study, it's in 2022. Oxybutynin is the most common drug to treat overactive bladder syndrome. Transdermal administration is the ideal route, replacing oral administration to resolve problems of low bioavailability and severe side effects. However, commercial products frequently cause skin irritation and low permeation. And so they were testing a new gel. They reduce skin irritation. They say it's excellent drug loading, low toxicity, easy scale up, is a promising strategy to ameliorate skin permeation of insoluble oxybutynin for better treatment of OAB. Of course, that's not really that helpful because it doesn't give us effectiveness, right? I would like to see data on um, okay, here's what researchers I really respect. Let's see what they find. Well, I'm not seeing results, hun. I'm not seeing results in these studies. I mean, so I don't know anybody who's used it myself. Oxybutynin is all about calming bladder spasms. And so if you have bladder spasms where literally as you're peeing, there's the last couple of drops of urine are coming out of your urethra, and you get a really strong cramping sensation, that's usually how a bladder spasm presents. And oxybutynin is a great way to turn that spasm off. It will usually turn it off in about 20 minutes if you're taking it as a pill. The challenge is that oxybutynin, if you take it by mouth, is an anticholinergic. Has a lot of side effects: dry mouth, dry eyes, weight gain. Well, no, it's not weight gain, but dry mouth, dry eyes, but cognitive decline. So they're being very cautious now about prescribing these bladder antispasmodics to older women who, and to anybody older. If you're over the age of 50, they're going to really think about it first. And so most people transitioned instead to a medication called mirabegron or Mirbitriq, because that's not an anticholinergic, but it can still act to calm the symptoms of frequency urgency. Katie says, do I know of any correlation between IC and NuvaRing? It's not the first time it's come up. We've had several patients who believe that NuvaRing played a role. Let me just look at the research. I don't see any studies which have made a direct correlation, but I will say that patients off and on, including in these meetings, have asked that same question. Wendy says, amen, you work in healthcare. Yeah, I think we need to thank every doctor who's working with us right now, every nurse, everybody, because I think it's a battlefield. I think that the insurance companies are crippling healthcare right now, United Healthcare being the worst. And the stories about United Healthcare denying treatments are just heartbreaking. Kathy said there was no event that she associated with the onset of her IC. She had a flare-up last year while drinking the Starbucks medicine bomb. I love the Starbucks medicine bomb, but the problem with the Starbucks medicine bomb program is it used a green tea. It was a mint green tea, and that green tea is devastating to an IC bladder. Very, very acidic. So if you're older, if you're in estrogen atrophy and the underlying cause of your symptoms is just your skin getting a little bit weaker because you're older and you don't have enough estrogen to produce mucus, girl, that green tea is going to mess with your bladder terribly. And I was working with a patient just like literally 2 days ago, long history of Hunner's lesion. She knows she can't drink coffee. She knows she can't drink typical tea. She started drinking matcha, which is ground up green tea leaves, and she was really struggling with that too. So Kathy, my workaround for so for those of you who don't know, the medicine bomb variation of herbal tea at Starbucks was created by a patient like 10 or 15 years ago who was very, very ill with the flu. And it was a hot, a mint tea combined with peach tranquility, which was wonderful. And then if you didn't have IC, that you did it in a base of hot lemonade and with honey. And I'm telling you, this medicine bomb, if you ever were digestion, had congestion, sore throat, the medicine bomb variation that this one patient came up with was freaking awesome. As an IC patient back then, I wasn't drinking lemonade, so I didn't do lemonade, and then I did an herbal mint instead of the green tea mint, and I was able to do it. Now I can do hot lemonade. In fact, I've been drinking a little bit of very diluted lemonade, but I didn't drink lemonade for 30 years. I can drink it now because my pelvic floor is better and my bladder has healed. So you started drinking the chai teas from Starbucks with black tea, and it started a week ago. But chai tea is just as bad. It's just as bad because it's black tea, girl. It's black tea. It's acidic. If you're going to do a chai, you need to do a rooibos chai, like Numi's rooibos chai. You'd be better with that than doing any black tea based chai. Becky said, our doctors are only allowed 15 minutes with the patient. True. Angie said, my urologist and pain management doctors both retired at the same time. Yep. Pamela said, true. I went off of it with the eye issues. Tina says, thank you for the info. My symptoms started and were diagnosed following COVID. So Tina, you have COVID cystitis. And COVID cystitis I have a website on it, covidcystitis.org. So we found that 2 months after the pandemic started, researchers in Italy started noticing that all these patients without any history of urinary issues all presented with overactive bladder IC-like symptoms. And they published a paper on it like in April of the first year. I read the paper. And then researchers in Michigan who were also working with COVID, urologists, did their own study, and they found that COVID cystitis does occur, that the cytokine storm markers that would damage the lungs were also found in the bladder wall, were also found in urine, but they also found living virus in the bladder wall. The COVID virus was isolated in the bladder wall, in some of the most ill patients, not in all patients, but in some patients. So COVID cystitis is real. Now, our study with COVID and IC found that 75% of IC patients who got COVID flared, and 25% of them had very, very severe flares that lasted for 6 months to a year, but it did eventually go away. And that's just that inflammatory cytokine storm. Marie says, I have Hunner's lesions in the Epstein-Barr virus, so this is very curious. So Marie, they are already testing antiviral medications. That's why our AUA meeting is so important, because they presented another study last year of the first study that looked for the virus. And if it found the virus, they gave these patients an antiviral. And when you put them on the antiviral, the Epstein-Barr virus disappeared and symptoms improved. So I'm hoping this year we will have another follow-up study to that. But the abstracts for this year, the research for this year won't be released until April. Deanna said, is there anything I can do to prevent the lesions from growing back? Well, so no, we have to understand what's causing the lesion. So again, concept number one is it might be a virus. So if you have a history of Epstein-Barr or polyoma, then you're going to want to do things that are antiviral, like lactoferrin. One thing I would definitely do is lactoferrin, because we had that study come out last August, which showed that lactoferrin basically made red inflamed bladders turn pink and healthy. Lactoferrin comes from colostrum, which is part of milk, mother's milk. Lactoferrin is the front line of our own immune system. It has antibacterial, antiviral, and antifungal properties. And in that study, 31 patients, 28 out of 31 at the end of 4 to 6 months had their red inflamed bladders had become pink and healthy. Their IC symptoms improved. And most importantly, their inflammatory markers that were measured in their bloodstream also improved. So if you want to try something really easy that could really help, I would do lactoferrin. You can find it in the IC Network shop. Our challenge with lactoferrin is that there's all sorts of lactoferrin on the market. Lactoferrin is destroyed by digestion. So how it is delivered is important. We call that a drug delivery system. So you don't want to buy the cheapest lactoferrin you could find, because the odds are it's in a cheap capsule and it's just going to get fried by your stomach acid. You need to up your game a little bit. The other challenge we have with lactoferrin potentially is that lactoferrin comes from cow's milk. And right now here in the United States, we have a lot of cross-contamination with bird flu. And bird flu has been found in milk in grocery stores. We just had another, like 2 weeks ago, another recall for another milk because they found living bird flu virus in milk that people were buying in a grocery store. So I chose not to bring in a lactoferrin from the United States. I found one from Australia where there's no bird flu. Because I'm just too uncomfortable with it. We just don't know enough right now, in my opinion. Now, the other thing that we know can cause Hunner's lesions is a damaged ligament. So let me explain this. We had a study a couple years ago. It was a case study of a woman with severe Hunner's lesions who had a severe prolapse. And when they went in to surgically repair her prolapse, they made a remarkable discovery that her ligament was broken and her uterus was backwards. It was basically swinging on one ligament, and it was grossly out of position. So when they untwisted it and tacked it up into the correct place, and they repaired the prolapse, something absolutely remarkable happened. That her severe lesions disappeared completely. Completely. She's considered a complete and total cure. Now, this supports the theory that a lesion can also be caused by severe neuroinflammation. Nerves that become very, very, very inflamed. Nerves that become inflamed release toxic substances one is called substance P, and substance P damages tissue. So this is the lead story in my magazine that's going to be at the printer on Monday. Because we have yet another study which has identified um, something called posterior fornix syndrome as a cause for lesion. So let me explain it to you. It's all about a ligament, your uterosacral ligament. So this is the ligament that holds the vagina and uterus in place. But it also holds nerve bundles in place, specifically something called the visceral plexus. And these are nerves that come out of the bladder and go up to the spinal cord. Okay, and the same nerves come out of the vulva and the vagina, and the same nerves come out of the GI tract. And so these are what we call afferent nerves. These are nerves that communicate up to the spine. They just communicate that way. Well, they happen to rest on top of the ligament. So if the ligament is damaged, this nerve bundle falls down. It gets pulled down by gravity. And when you walk, it's pulling the nerve downwards like this. And that's stressing the nerve. And that's causing the nerve to send impulses up to the brain going, help me, help me, help me, there's a problem. And your brain because these nerves come from the bladder, even though the pain message is not coming from the bladder, the pain message is coming outside of the bladder. The brain goes, oh, there must be a problem with the bladder. And so the brain starts giving you urinary symptoms, frequency, urgency, pressure, pain. Even though it's not originating in the bladder, it's originating right out of the bladder in this visceral plexus. So we had yet another research study that with a large group of patients who had IC symptoms and who also had a history of prolapse. And they were able to make that correlation with this ligament as the underlying problem for their urinary symptoms entirely. And when they repaired the ligament, the urinary symptoms went away. One of the other ways that they validate this, if it's a structural issue, so we've got this nerve that's being pulled down, right? So, and this would be the vagina, right? No, I'm sorry. This is the ligament. How do I want to say this? Okay, this is the ligament that's holding the vagina right next to it. So one of the treatments for prolapse is a pessary, where you put an object in the vagina to just hold everything in place. And what's so interesting is when you put the pessary in and you look at nerve function and it improves it, which then proves that symptoms are being caused by a structural problem as compared to a disease problem. I hope that makes sense. That's the lead story in our upcoming IC Optimist magazine. I could have printed it out, but I didn't. It's going to the printer tomorrow. You will see it next week. Mary says, do you know much about urine cultures? I do. Why are they only culturing for 24 hours? It's cheaper. That's why. Marie said, that was not long ago. Wow, God bless. Okay, there you go. Lori says, anxiety about pain. Wish I could find someone who specializes in medical anxiety. Lori, I found one on BetterHelp. I went to betterhelp.com, which provides online therapy services or counseling services. And I specifically requested a therapist who was a woman who was in her 40s, 50s, or 60s. I don't know how old she is, but she's near my age, who had a specialty in medical anxiety. And it's been wonderful. Wendy said, not trying to get into your business. Have you ever taken any anxiety meds that have helped with your nervous system and your pelvic floor? No, I happen to be somebody who reacts to almost everything. And so I have a real bad problem with side effects. The only medication which I've been able to take consistently over time was Vistaril, which is an antihistamine that has a very mild anti-anxiety benefit. And it's just very hard. I mean, like literally a week before my breast cancer surgery, and I was just like, My anxiety was, woo, I was scared to death. And I emailed my doctor and I said, hey, you know what? I'm really scared. Is there any way I can get some anxiety meds? And they like pushed back and said no. And I was just like, really? I'm not asking for a year's supply. Just give me like a pill a day through surgery so that I'm not hysterically crying out of fear. Angela said, am I familiar with eosinophils in the bladder? Yes, I am. I have worked with eosinophilic cystitis patients. What's your question? Jenny said, is Hyprex and Cystex not the best fit for a bladder that's very food sensitive? I took Cystex the last couple days, had burning increase with Cystex before trying Hyprex. It's a lower dose. Honey, I know, but see, the thing is number one, those aren't treatments for IC. And it depends upon your phenotype and what kind of flare you're having. So if you're having a pelvic floor flare, it's going to do nothing. If you're having a bladder wall flare from the food, you need to do the food protocol. We need to alkalinize your urine and dilute your urine so it's not being provoked by acid so much. But these are meds that are not suggested for long-term use. Angela said she's used oxybutynin, and yeah, I used it too. Cindy said that's exactly when mine started with COVID cystitis. I'm 2 years still struggling. I found that after taking Paxlovid and prednisone, 2 separate cases of COVID, I had no IC symptoms for months. Good. Jenny said, with lactoferrin, should I take daily dose together at once or spread it out through the day? I would spread it out through the day. I would definitely spread it out through the day. And again, guys, on Facebook, just please know that Facebook messes with me all the time, and I miss messages all the time. If you asked a question and I missed it, please, please, please ask it again. Please do not take it personally. All right, let's go back here to YouTube real quick. Hello, YouTube. Debbie says she's always swearing in the doctor. I don't swear in the doctor's office. I swear in the car afterwards. I do not want to alienate my doctors in any way. I don't. Janelle said, does pumpkin seed oil help with flares? Not that I know of. And again, it depends, Janelle, it depends upon the type of flare you're having. Is it a bladder wall flare or a pelvic floor flare? Is it a stress flare? Is it a hormone flare? Joni says, I'm hoping to reduce my venlafaxine, which was prescribed for pain, and transition to PEA. How much PEA do I take? Hey, girl. Hey, Donna. I do 2 capsules, 1 or 2 capsules at night. I have the Piora. I love that stuff. I mean, my skin is so much better with PEA. Because I have small fiber polyneuropathy. Small fiber polyneuropathy is very common in redheads, but it's very common in patients who have widespread pain. It basically means that the tiniest nerves in the surface of your skin have become very, 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 very sensitive. And so, for me, I don't know what happened after menopause, but it just got 1,000% worse. And I started having trouble sleeping. Like I felt like I was being poked by pins all the time. And I would have a big tub of lotion in bed with me. And it was like I was chasing dry skin everywhere. That dry, prickly skin that you sometimes get in the summertime. Man, that was every night for me. And then the PEA came out and I waited a couple months because, again, I'm super sensitive and I never know how my body's going to react. And finally, I just couldn't. I was like needing Norco to even try to sleep. That my skin was so messed up. And I thought, what do I have to lose? I'm going to give it a shot. PEA, excellent side effect profile. No side effects in the IC study. No known drug interactions. I'm like, you know what? I got nothing to lose. I'm going to give it a try. And my skin is 1,000% better. 1,000% better. It's amazing how much that has helped me with my small fiber polyneuropathy. I was working with somebody earlier today, a friend of a friend, a woman who has burning mouth syndrome. And burning mouth syndrome is like a neuropathy in your mouth. The nerves in the mouth become very, very damaged. And so it's like you have acid in your mouth all the time. And this patient, it happened after she was in the military, and she had an accident in the military, and it just triggered these nerves. And she's incredibly despondent right now because she can't taste anything. It hurts her to talk, or just her mouth is on fire. And again, we call this burning mouth syndrome. And I gave her the 2 studies with PEA and burning mouth syndrome because I think it's worth a shot, because it showed effectiveness. It did. Um, McKen, if you're still here I'm sorry I missed your message. She said she has Hunner's lesions and she's new to IC care. Are installations the first treatment recommended for Hunner's? No, not at all. No. You need to come over to the IC Network website, icnetwork.org, and read our section on Hunner's lesions. Hunner's lesions require lesion-specific therapy. So do not expect medications like Elmeron or bladder installations to help a lesion. You can inject a steroid into it. See, the thing about lesions, Hun, is that when you biopsy a lesion, it is massive inflammation. There is literally a warfare happening in the bladder of somebody with a Hunner's lesion. And now we know what could be causing that war, which is a viral infection. And so treatments are focused on reducing that inflammation. And so you can, number one, inject a steroid into the lesion to calm that down, or they can cauterize the lesion. But if it's driven by a virus, you might want to consider an antiviral. And the viral research helps us understand why lesions sometimes recur, because the virus is still active. And so again, that's why this new research with antivirals is really, really important. But now we have the lactoferrin, which is a very simple over-the-counter supplement derived from milk. It is not a chemically synthesized treatment where we're going to see a lot of side effects. I mean, if you can drink milk, the odds are you're going to be able to take lactoferrin. And the IC study that came out last August was just spectacular. We have a blog on our website. If you go to icnetwork.org, just scroll down to the research area. I've got the research citation. You can look at the research. I give the background on it. And so to me, first-line treatment for Hunner's lesion now would be lactoferrin based upon that study. Because then you don't have to have a hydrodistension. You're not risking scarring the bladder, etc. So that would be fascinating. And of course, if you've got Hunner's lesions, you've got a wound in your bladder. So you got to be really careful with your diet right now. No coffee, no green tea, no black tea, no soda, because you have the equivalent of wounds in your bladder wall. And so your job as a patient is to create an environment that will help protect the bladder and give the bladder time to heal. The last thing we want to do is pour acid on a wound. So diet modification is by far the most important for patients with Hunner's lesion. So I have a whole section on our website on it. We have a whole website, hunnersulcer.org or hunnerslesions.org, where we've got a lot of good information over on that website also. Joni said, I have burning mouth, but it comes and goes. Doesn't seem that bad. Yeah, you know, Joni, I've had burning mouth off and on too. Definitely related to menopause. Burning mouth is very common after menopause. And you're right, it comes and goes for me. I get the tip of my tongue gets really sensitive some nights. And I have a gap between my lower front teeth that my tongue plays with, that it just constantly plays with it, and it gets super, super irritated. Jenny, Mary, okay, here, hold on. That I guess Hyprex works better than Azo. Okay. And Jenny says Azo's never worked for me. I will tell you that Azo never worked for me either. But the reason why it didn't work for me is because I'm pelvic floor driven. It wouldn't have worked for me. My bladder has always looked normal. And that's the thing that's just so freaking confusing here. Is here you're peeing every 15 minutes, you're in a lot of pain, you're in a lot of discomfort, you're food sensitive, you're like, sure, you've got a bladder something. And they look in your bladder and it comes back normal. And you're like, what? How is that even possible? How is that possible? Well, the way it's possible, I mean, so you got to follow the data here. If you've got a normal bladder, you got a normal bladder. So what that means is your bladder wall's healthy. It's your muscles and nerves that are the problem. And so now we have to now we have to figure that out, which is why you need to go have a pelvic floor assessment and let's see if your muscles are tight. If your muscles are tight, then we have to work on that. Tight muscles are bad. Tight muscles restrict blood supply. We need we need good blood flow. We need healthy, normal muscle tone, not tight muscle tone. And you can tell your muscle tone every day just by how you pee. I mean, when I peed this morning, it's so weird. After my mastectomy, I became just a little bit incontinent. And it was when I was just really like, I was in a terrible pain. And it turned out I had a post op infection and I had to go to the emergency room. And as I was getting ready to go to the emergency room, I just let it just happened. Like, woo, look at that, just coming out. There's no control here. Just trickled out. I could feel it. So I ran to the bathroom and I had to change I was wearing a mini pad, so I had to change my pad. That's probably happened 3 times in the last 7 months where I just like feel awful for one reason or another. And it happened. And so because I'm prone to very tight muscles, and incontinence is normally about weak muscles. And so I was like doing some kegels afterwards going, oh, that does not feel good. So it's very clear that I have to go back to physical therapy and see if we can figure out what that is. Cindy said, my bottom lip blisters when I'm in a big flare. Now, Cindy, that's fascinating. So, of course, herpes infections. I get herpes blisters too, herpes canker sores. I mean, most people do. I think they said like 85% of the population has oral herpes. So oral herpes is known for triggering during periods of very, very intense stress. And so when my parents died 2 years ago next June, I got the biggest cold sore of my life. You guys didn't see it because I did not do a live meeting, obviously, because I was in terrible grief and crying all day. I mean, it was like, it was big right here. And it was just a stress-induced thingy. Crazy. Sue says, I do the same thing with my tongue, and the gap in the front of my teeth actually chew gum to stop myself from doing it. It makes the tip of my tongue sore, and I also get burning mouth if I'm in high times of stress. Yeah, Sue, girl, like we are such sisters. I put a Tic Tac in my mouth to keep my tongue busy, but also they don't have as many calories. I use wax. I always have a little piece of wax between that gap in my front teeth to stop it. Mary says, depends on who does the cystoscopy. I had a cysto. They said all good. Had another one by a different doctor using a more flexible scope, and he found a mess in my trigone. Yeah, that's flexible cystoscopes. Girl, it's all about technology. Some doctors are using old cameras that do not have good definition, but these new flexible cystoscopes have much higher definition. And it's about, will the doctor and their clinic pay to update their equipment? Some will and some won't. Jenny said, my burning and urgency gets really bad after urination, then somewhat settles with the bladder filling. Is that pelvic floor? Yes, that is pelvic floor. Unless the burning is on your skin. Where is the burning? Like if your urine feels hot while you're peeing, we call that urine burn. That also could be estrogen atrophy on your vulva and in your urethra. Pain as the bladder fills with urine is associated with the bladder wall. So if your pain gets worse as your bladder fills with urine and you feel better once you pee, then that tells me your bladder wall is part of the problem. But if you're the opposite of that your pain is worse after you're done peeing, that points us to muscles. Okay, Jenny said the urethra burns inside. Estrogen atrophy, girl. How old are you? Here, let me turn on this little heater. I need to turn this on. Estrogen atrophy, my friend. The urethra is the canary in the coal mine when it comes to estrogen atrophy. And so if you get to that moment when your urethra starts burning and your urine feels hot, that's usually the skin. And girl, that happened to me when I was 52 and you're 52. I'm getting closer to cutting all this off. All right, Mary said, unfortunately, removing all of it made my symptoms worse, so I have no idea. Definitely my bladder wall. Can estrogen atrophy affect the bladder? Absolutely. Estrogen atrophy does affect the bladder wall. Definitely. If the bladder doesn't have estrogen, then it's not able to produce that nice, thick protective coating you need. That's called, Mary, that's called the genitourinary syndrome of menopause. So yes, estrogen atrophy does directly affect the bladder wall. Jenny says, how long does it take for estradiol to make a difference? 3 to 4 weeks, hopefully. All right, let's go back here to YouTube. Diane says, I've been trying the lactoferrin, but end up having to stop after a couple days because of painful abdominal bloating. I think you need to test for SIBO and treat that again, but hate taking antibiotics. Yeah, I mean, that's the thing is lactoferrin, because it's a natural antibacterial, antifungal, it's going to boost your immune system. And if you're in a state of SIBO or you have an overgrowth of fungus, your body's going to start killing that. And that's going to potentially give you some gut symptoms. That's really the only symptoms that are associated with lactoferrin in some patients. Michelle says, I don't have Hunner solutions. They cauterize them now. See what she calls it, a cascading waterfall on my bladder wall. Yeah, that's called hemorrhagic cystitis, or they call it a waterfall effect. It's like a waterfall of blood coming from the lesion. Pretty awful. Pretty awful. Look, you can see how tight my neck is. My head is tilted. Ah. Mary said, I think no estrogen caused my trigone to get all that mess. Yeah, it probably did, honey. It probably did. So, Michelle, are you still bleeding now? Do you have visible blood in your urine? I mean, let's talk about that for a moment. Blood in your urine. Microscopic blood in your urine is very, very common. I think every single time I've had a urine test, I've had microscopic blood. Visible blood is not common. And so anytime we have a patient where there's visible blood, like literally your toilet's filled with it's pink urine or red urine or blood clots, very, very important that you tell your doctor about that because they need to check that out. And our IC guidelines, when they were updated in 2022, they really emphasize that for the first time, that we don't want to ignore visible blood, that the doctor should be making an attempt to understand where that blood is coming from. Visible blood in your urine can come from Hunner's lesions. It could come from an infection. It could come from a bladder infection. It could come from a kidney infection, but it can also come from bladder cancer. And so they would normally check all that out for you to see what you've got. And the thing is, we probably all in our diagnostic workup got tested for cancer anyway. It's called a urine cytology test. That's a normal part of the diagnostic workup, is to rule that in or out, especially if you have a history of smoking. So don't ignore pink urine or blood clots in your toilet. That is a definite immediate call to your urologist the next working day and say, hey, I'm peeing blood. We need to check this out. Most of the time it's an infection, but let them do their due diligence and figure it out. Wendy said, do you think anxiety meds would help regulate my nervous system? I think that if you're struggling with high levels of anxiety, knowing that that's exacerbating your pain and amplifying your pain, if it will bring your anxiety down, then that's reasonable and that makes sense. But in the same sense, ideally, we don't really want you to dependent on a medication to bring your anxiety down. This is where learning new anxiety management skills, like I have a video, an IC anxiety video that I filmed several years ago on the class that I took that completely changed my life. I took it when I was 35. I mean, I had been scared since I was a kid, since I was attacked as a child. I've been in fight or flight from 4th grade to the age of 35. And that's one of the reasons, well, it was one of the foundational reasons why I ended up with all the related pain conditions, the IBS, the vulvodynia, the TMJ. A lot of that comes back to trauma, physical trauma or emotional trauma. And I was stunned that when my anxiety went down, my pain went down. And now we have so much more insight into what we call adverse childhood events causing prolonged intensive anxiety in adult for that child when they become an adult. And there are many patients that I've worked with who've just been living with anxiety their entire life. Like every day now, I talk with somebody with chronic anxiety. And we had research years ago that showed anxiety was very common in the IC patient population. But now that we're phenotyping, the anxiety is the most common in patients with widespread pain, which again is connected to adverse childhood events. And so this is where you can't be offended when somebody says, hey, how about a little therapy to learn some new anxiety management skills? Never be offended by that. I mean, I was offended. My doctor, my first appointment, Dr. Klein, I loved him. He wanted me to go to psychology when I told him my history. And I was like, oh, hell no. No, I'm peeing all night. Don't tell me this is all in my head. Don't tell me this is anxiety related when I'm peeing all night. Clearly it's my bladder. And, you know, I blew him off. He was absolutely right. And, you know, I'm really grieving the fact that my entire life was influenced by childhood trauma. And I can see now at the age of 64 how in my 20s, 30s, and 40s, how anxiety prevented me from doing a lot of things. And I weep for that young girl because it was never my fault. I didn't do anything wrong. I was attacked by a guy who became a rapist and a murderer. And I can just remember when I took the anxiety management class, how when we actually got the anxiety under control by getting rid of the adrenaline, all the negative thoughts stopped. Because the thing is when you struggle with anxiety, you are in this vicious cycle of negative thoughts also, because that's your brain. I mean, fight or flight is all about your brain remembering trauma and trying to keep you safe. My brain says home is safe, leaving home is scary because I got attacked by a guy who chased me to school and back. My safe place was home. So, 60 years, 55 years later, my brain, my personality schema still interprets life that way. Whenever I go on vacation, I'm always thinking about getting home. My brain says, go home, you're safe at home. And I'm not lying. I've been to Europe, I've been to Hawaii. I never fully enjoyed it because my brain was going, you get to go home in a week. You get to go home in a week. It's important. Go home. That was caused by childhood trauma. And now what's interesting is one of my friends who was also a childhood trauma patient, her trauma happened at home. Home was not safe for her. She was safe when she left home. And so she loves traveling. She doesn't like staying home. And even though she's not in her parents' home and there's no alcoholism in her home, she had a very, very violent alcoholic parent. That's a common theme. She grew up loving to travel. I grew up hating travel. It's so interesting how our brains compensated for trauma in that way. But now that I see it clearly and I understand it and I see how it affected my life and it limited me. I could have gone to med school. I could have done a lot more different things than I chose to do because my brain said, stay home. And, I just think about all those lost opportunities. And now today I'm like, listen, man, if I'm lucky, I've got 30 more years. I'm 64. And thankfully in my family, there's no history of dementia, knock on wood. Hopefully the brain stays. I want to enjoy this now. I sincerely want to enjoy this. And the cancer didn't help because now I'm back in the stay home, mode. But I recognize it and I'm working on it and I'm getting therapy for it. I'm trying. I'm really trying. And like the single most important thing you need to hear from me is none of it. If you're in that widespread pain group, this is not your fault. You have done nothing wrong. No shame, no blame. You got hurt. I got hurt. You could have been hit by a car. You could have had a severe injury, like breaking a leg. I've worked with a lot of patients who have a physical injury. About 80% of children develop widespread pain as an adult, have major physical injury. But for the other 20% of us, it's emotional trauma. My brain learned to live in fight or flight every day for a decade. Legitimately, because it was trying to save my life. Michelle says, would PEA help? PEA definitely calms nerves down. I'm a huge fan of PEA. McKinn says, my urologist can't see me until April. Is there anything I can do besides diet to help Hunner's lesions issues? Yes, lactoferrin. Try the lactoferrin. Go to our website, front page, halfway down, it's a blog with the new lactoferrin IC study that came out in August. About a 4-month study. Go for it. You got nothing to lose. It might help. And that study very specifically found that Hunner's lesions basically disappeared, almost completely disappeared. As a direct quote out of the study. So I would do the lactoferrin. If you're lactose intolerant, can you do it? Yes, because, and I asked the company that because there's no lactose in lactoferrin. Lactoferrin is a protein. And so there's not enough of lactose in it to trigger a reaction. I asked several people that question. They all said it's not a problem. But you won't know until you try it, but I would try it. Anne says, after pelvic floor physical therapy, what are your thoughts on doing an upper cervical chiropractor? Yikes. Yikes. What would an upper cervical chiropractor do? I can't even imagine what, I mean, there are some, I can still remember a patient who went, oh, wait, here. So Carla here, well, here, hold on. Jenny says, lactoferrin has helped my brain fog a bunch, hoping it will help prevent UTIs as well. How long can you stay on it? I don't see, I mean, there's no data about long-term use because it comes from milk, honey. So, here, hold on. Whoops. Let me see if I can find a lactoferrin long-term use study at the National Library of Medicine. Oh my God. Oh my God. This research is so encouraging. Literally, the most recent study came out this month. Lactoferrin alleviates the adverse events of early life inflammation on depression in adults by regulating the activation of microglia. Listen, what were we just talking about? Adverse childhood events. Lactation, so breastfeeding, is a crucial phase of brain development, and the events and nutrients provided during this period have long-term consequences for the occurrence of depression. This study investigated the effect and mechanism of lactoferrin deficiency during lactation on depression in adulthood. Lactation deficient mice were established by nursing wild type mice. Okay, so it's okay, hold on. The results show that lactation lactoferrin deficiency increases depression-like behavior in adult mice, and the mechanism is associated with heightened neuronal damage, abnormal microglial activation, and decreased BDNF in the hippocampus. I don't know what BDNF is. In contrast, recombinant human lactoferrin promotes neuronal proliferation by upregulating, and attenuates neuronal injury. Wow. Our findings suggest that lactoferrin intake during lactation protects nerves by regulating microglial activation, thereby effectively reducing depressive symptoms in adults. Wow. 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 Because you have to understand that childhood trauma and being in a state of fight or flight enhances inflammation throughout the body. And so here they're saying that lactoferrin reduces that inflammation, which then reduces some depressive symptoms. That was this was a study from the College of Food Science and Nutritional Engineering in China and the International Peace Maternity and Child Health Support Child Health Hospital in Shanghai. Wow. Okay, so let me just go back to a clinical study to evaluate the anti-inflammatory effect of lactoferrin in chronic kidney disease. Effective. In bovine mastitis. Effective. In liver cancer. So for example, why do women who have breastfed have a lower risk of breast cancer than women who have not had children? So I have not had children. I have not breastfed. I had one miscarriage when I was very, very young. And I got breast cancer. And so they think that correlation is actually the act of nursing improves and enhances the production of lactoferrin, which actually has anti-cancer effects also. So anyway, so Carla said, I'm in month 3 of lactoferrin. The relief has been amazing. It even helps me with a constipation. Yes. Yes. I'm so happy for you, Carla. Wendy said, do we sell PEA? You better believe we do. It's in the IC Network shop. It comes from Australia. Just go to icnetwork.org and click on our store. Deanna said, I just had my Hunner's lesions burned off. Should I start the lactoferrin? Could it prevent them from growing back? Well, it's going to fight a lot of that inflammation. I don't know. I don't know what it's going to do, but the research is looking pretty fine, hon. The IC study found that red inflamed bladders became pink and healthy, and Hunner's lesions improved. And they were almost completely invisible. So I would say, what do you have to lose? I mean, you go to our website, read the article, look at the research study yourself and see what you think. But to me, because we've had so few options for Hunner's lesion patients, it's like, why the hell not give it a try? Debbie says, where do you get that from? What, PEA? It's Peora in the IC Network shop. Okay. Janelle says, a doctor prescribed low-dose naltrexone. Okay. I'm unclear as to which phenotype low-dose naltrexone would be the most helpful for, to be honest. Michelle said, would lactoferrin help with a cascading waterfall bleeding as well? And can I take the PEA and lactoferrin? They should be fine taken together. Neither one of them are known for having drug interactions. They have completely different methods of action. And would it calm the inflammation that's causing the bleeding? It could. It could. Look at the study. You know, I can give you here. Hold on. Let me just go ahead and give you the link to that. Hold on. So you guys are on different computers. So let me give you the direct link to what I wrote on this. All right, Michelle, here's the link. There you go. And you guys on Facebook, let me give you the link too. Hold on. I mean, like, I'm just super excited about it because, I mean, look, we just had 2 patients just in the last 5 minutes say they're significantly better with lactoferrin. I think that that's really exciting. All right, so for those of you on Facebook, here is the link to the article I wrote on this. This is the lead story in our magazine also. You're welcome, Michelle. You're welcome. You know, I've been running the IC Network for 30 years, and I've been a support group leader for 30 years. And when I started the IC Network, you know, we were really successful early on. I mean, We were the first website ever built on IC 3 years before the ICA. I already had a lot of experience, obviously with my degrees in psychology, a master's degree in psychology, and a degree in pharmacology, and another degree in chemistry. So, I knew how to curate the information, and we were honored with the National Cancer Institute, literally our second year, as one of the best health websites ever created. I mean, that was amazing. And I was very academic back then, very academic. I didn't talk about peeing and pooping. I talked about urination and defecation, and I was just like, because I was, my goal for the IC network is I wanted it to be I wanted 30% of it to be helpful for patients, 30% of it to be helpful for researchers, and 30% of it to be helpful for doctors. And, it's been wildly successful. But the internet's changed. A lot has changed. And I've changed. And when you work on the internet and when you're writing things for the internet, you can't be that academic anymore. That the writing level is like your target is 7th grade reading, and it's really hard to do medical education at a 7th grade reading level. And it's really interesting working with patients because, like, I had a doctor call me with IC last week, and man, we just had the best discussion ever. Like, all the science, all the hard news, extremely academic. And I mean, I can go to town on the science to really help people understand it. But then you work with somebody who hasn't graduated from high school. And it's a very different challenge to try to explain this to somebody who they don't know where their urethra is. They don't know, they've never looked at themselves down there. They don't want to look at themselves down there. They, again, last week I was working with somebody who didn't know what a vulva was, didn't know what a labia was. And she was like in her 60s, had no clue. So anyway, when I do these meetings, I'm not interested in grandstanding, and I'm not interested in trying to make myself look good by being super, super academic. I just want to get to the message as quickly as I can and as easily as I can. And I think you can see that there are moments when I'm a nerd and I love the science, and there are moments when I just talk about peeing. Does it hurt? Does it hurt while you pee? Does it hurt before urination, after urination? So it's very interesting how things have changed. And, we're at a very, very different space and time. Like, as an example, I have been working for the last 2 years with the American Urology Association. I'm a committee member for the development of new guidelines for men with pelvic pain. We have guidelines for IC, and now we have guidelines for men, because I'm telling you right now, for the men out there, men do not have the resources that women do at all. And men face very, very unique challenges and they don't have a place to talk. They can call me. The men are kind of my subspecialty in IC. I love working with men. Believe me, if you're a man struggling with this, call me. I would love to talk with you. So anyway, we've got this fabulous new set of guidelines on how a urologist should do a diagnostic workup for male pelvic pain. And the answer I posed to them yesterday, as I signed off on it, we're all signing off on the final product now. And I said, something like, fabulous work. I mean, I was just so honored to be a part of this committee and to have a voice and to share, the patient side of this. Like one of the things that I contributed was to ask urologists to ask men if they were athletes. It's that simple. Because if you were a football player when you were younger, or if you played, I was working with a guy last week who was a big time baseball player, and he played for decades. After he played collegiate baseball, he played for another 20 years. And so he had all the symptoms of IC and pelvic pain. And, and he's like, okay, were you an athlete? He goes, yeah. I was like, what was your sport? Baseball. How long did you play? Oh, about 40 years. And I went, and he's like, well, why would that make a difference? And I went, how many times did you slide into home base, dude? He's like, oh. Every time he slid into home base, he landed on his pelvic floor. I have no doubt he is a pelvic floor injury patient. So anyway, what I said to the committee is that, God, we've got such a great document. We've got such great IC guidelines. Then we have a great set of male pelvic pain guidelines. How do we get doctors to read them? I mean, we've had IC guidelines since 2011. They've been updated 3 times. There are still urologists out there who've never read them. There's still urologists out there treating IC out of textbooks written in the 1980s. And they're getting it wrong completely. And so I proposed to them, I just said, I think now we have to really think about how do we get this information out? And I proposed that we do a series of videos. We'll see. If they don't, I hope they will consider it. Piano says, I like the decorations you present in each video. You're very much aware of all aspects of human needs. Thank you, honey. I'm a very visual person. I'm a very visual. And if you could see my house, I mean, it's neutral with huge pops of colors everywhere because I'm very color driven. And I'm playing all the time. And I paint. So right now I have probably about 12 or 13 of my own paintings. And I'm constantly moving them around and just playing. I just want it to be, that's very much me. Thank you. That's how I relax. Penny said, my father died in December. Penny, I'm so sorry, honey. My husband just survived a widowmaker. Oh my God, girl. I thank my doctors for the LDN or I'd be in horrible shape. The key is to stay on it. It takes months to even notice a change. Whew. Penny, you have been through 2 of the most stressful events that a person can go through. And that is the death of a family member and the near death of your spouse. How are you holding up, girl? How are you holding up? I had not lost anybody in my immediate family until I lost my parents 3 days apart 18 months ago. And I am in awe of the devastation of grief. It is just such a force in our lives. And I had oh my God, I had 2 nights ago. Hi, Julie. I'll tell you, 2 nights ago, I woke up at 5 in the morning and I had a nightmare. But it wasn't a bad night. It was just like a powerful dream. And I dreamed that my father, my elderly father, who was 100 years old, had come in here on a Sunday morning while I was sleeping and disassembled my entire streaming setup. And then he was laying on the floor, not looking well. And in my dream, I was like, what did you do? Oh, what did you do? Oh, and then I swear my mom and my aunt visited me a week ago, you know? I just try to be open to the possibilities. Janelle says, "Do I still get flares?" Yes, I flared yesterday. I have pelvic floor flares. Yesterday, I peed 4 times in 2 hours driving around with my sister. What my pelvic floor is right now going through a weird tight thing again. And, I hadn't drunk any water. So the mistake that I made yeah, the mistake that I made yesterday, not re is that I didn't drink any water. I mean, I had a little bit of water when I took my meds in the morning, and I desperately needed to get out of the house, so I went to the farmer's market, which is across town, and I brought Gatorade with me. And I really, really, really wanted to go up to my sister's house, which is like a 30-minute drive. But they all had the flu a week ago, and I'm like torturing myself going, do I go or do I not go? Do I go and expose myself to the flu or do I not go? And um, I got myself a little worked up. And then I got on the freeway to go. And then I went off the freeway and went, no, you should wait a week. And then I went, God damn it, no, I want to see my sister. I haven't seen her in 6 weeks. Got back on the freeway, drove up there, and I just kind of worked myself up into a little bit of stress combined with driving. And then we drove around for a couple of hours looking at tile and paint for her new house. So my pelvic floor feels tight today. And I woke up at 4:30 this morning with my left hip vibrating. It's still vibrating now. That's my thing is my SI joint's unstable. My piriformis muscle gets very tight and it starts squeezing nerves, and then the nerves get irritated and things start vibrating, and it's like that's what this fasciculation is in my left side pelvic floor. So annoying. Julie says, great to talk to everyone going through this. I just had Kenalog shots and the burning off. I will start the lacto. Yeah, I think it's worth a shot. Definitely worth a shot. I haven't so I took the lacto for about a month, and then I just got very distracted by the heart, this weird thing that I was having. See, and you guys just keep asking questions. When you have questions, I will convert to that. Otherwise, I talk about my life, and I apologize if you don't want to hear about my life. But it is what it is, because I'm a patient too, and I need support too. I will stop talking about me when you give me questions. My hot spot is right here, because that's where my mastectomy incision is. So my problem is, like, just touching that, like, oh, it's just so sensitive right here. And the problem is that if I walk, I get chest pain. And sometimes it's deep pain, sometimes it's shallow pain. And so there are times when it feels like it's my heart, when it's really not my heart, but it feels like it and it freaks me out. And I just did a bunch of heart tests. They've all come back normal. And yet, like, I woke up with this, but that was actually my hip, but I just felt it all the way up the left side of my body. Recovering from surgery sucks. So I have an appointment on Tuesday with a dermatologist. So I had a really good appointment with my primary care, who has been difficult. And I saw her last week, and I just I don't know what's going on. All I can tell you is that I just feel awful all the time. I mean, because the pain from this is like a 4 to 5 every day. sometimes, almost every day. So they're going to do injections underneath my scar on Tuesday. We'll see. John, hello, John. It's so nice to see you. How can you distinguish between prostate pain and urethral pain? Let me see. Let's see what the expert say. I mean, urethral pain you've been catheterized. You've had a catheter put up your urethra, and that kind of searing, sharp, intense pain, that's urethral pain. So the question is prostate pain sharp? I mean, urethral pain is like, urethral pain kind of makes you jump. It'll just, and that's a weird thing, is you just be sitting at your desk or sitting on the couch or driving, and all of a sudden you get a little razor blade feeling. It's like, bam, on your urethra, and you go, whoa, what was that? And it tends to be very quick, but then it kind of throbs a little bit afterwards. So to me, urethral pain is a very sharp pain. I think one of the things that you can do is look at your flow. Because if your prostate is enlarged, it is disrupting urine flow. Because the prostate tissue is emerging into the urethra. And so I think that if you're having to push to get urine out, if when you pee, your flow is thinner and tricklier, or even stopping and starting, that's more of a sign maybe that your prostate is messing a bit with how you urinate. A lot of guys have, I can remember when I started the IC network and I was building our section on male pelvic pain, and I was reading a lot about urethritis and urethral syndrome in men versus women, because men have a lot of urethral syndrome too. And generally, at least back when I was studying it intensively, it was being triggered by spermicides, that their tissue is being very, very irritated by birth control and spermicide, but also by laundry detergent and soaps and things like, when you think about the products that are marketed to men, they're going to be really strong detergent like soaps, strong scents, strong smells. Think Irish Spring, and think, and those chemicals in those are going to be very caustic and aggressive to tissue. So I remember reading a big section on that causing urethral symptoms in men. So you say you also get that hot urine burn feeling at times. Isn't that interesting? John, I think what would be really interesting, a lot of guys get pain at the tip of the penis, and they will describe it as and bear with me for saying this, but I'm just going to say it because I think women need to understand what this is like for guys. They will describe it as somebody shoving a knife up their penis. Like a really sharp, brutal pain, especially if they are ejaculating. That's brutal. So if it's coming from the tip of the penis, what would be interesting would be, would lidocaine help? That pain referred to the tip of the penis is often pelvic floor pain. That can be a pelvic floor spasm. That can be pelvic floor squeezing a nerve. So it'd be very, very interesting to see if a local anesthetic like lidocaine would help. I think, John, I mean, I think it'd be fascinating for you to try the lactoferrin. I mean, because you have had such intense symptoms for so long, and it's very clear that there's an inflammatory process going on. It would be fascinating to see if the lactoferrin would bring the volume down on all of that. Don't you think? Okay, guys, I need to go urinate. Could you give me 30 seconds? I'll be right back. We should all score. We should all score our trip to the bathroom. I'm going to give that one a 6. I didn't pee like a horse. I had good volume, but it was slightly restricted volume, and I feel my pelvic floor right now. Carrie says, curious if you've heard of anyone complaining of flares from GPL-1 meds. I recently tried tirzepatide and I had a flare. What did it say in the drug information sheet? Let's see if urinary, let's see. Well, yes, this medicine may cause acute kidney injury. This is from the Mayo Clinic. Check with your doctor right away if you have bloody urine, decreased urine output, muscle twitching, nausea, rapid weight gain, seizures, stupor, swelling of face, ankles, hands, or unusual tiredness or weakness. Decrease in the amount of urine, swelling of the ankles, hands, or feet. Holy moly. Okay, here, hold on. What are these guys? Hold on. Wait. What did she say here? So this is for type 2 diabetes or weight loss. It's one of those. And it's been linked to rare cases of acute kidney injury where the kidneys suddenly lose the ability to filter waste, leading to a dangerous buildup of toxins in the blood. That can cause dehydration and kidney strain. Yeah, so with the dehydration, your urine would become a lot more concentrated, which would be more irritating to your bladder wall, especially if you're in estrogen atrophy. Yikes. All right. Well, okay. So your flare doesn't surprise me given that. Katie said, what bronchodilator asthma drugs are the least irritating to IC? Okay, hold on. They talked about that at an AUA meeting in an IC class taught by Robert Mulder and Robert Evans about 6 years ago. And they talked very specifically about asthma meds. Hold on. It's right here. It's in this magazine. See? I still got it. I still got my memory. I just have to put on my reading glasses. Hold on a sec. Okay, so I know they talked about it here. Montelukast is what they recommended for patients with asthma. So Monte, M-O-N-T-E, Lukast, L-U-K-A-S-T. Straight from AUA 2018. You say albuterol bothers you, prednisone bothers you, dexamethasone bothers you. Okay, so Montelukast, that would be, see if that's a viable option. But, I mean, I'm not sure what the method of action of Montelukast is. I can only tell you that that's what they suggested to IC patients with asthma. And Katie, if you want, if you email me, I'll email you that magazine so you can read that yourself. It's literally just a sentence. Let me just read it to you. Hold on a second. Oral meds. So again, this was before phenotyping, right? So antihistamines, hydroxyzine, cetirizine inhibit mast cell release of histamines and can have a sedative effect. During allergy season, they suggested increasing the dosage and or also using a Montelukast, or using Montelukast, especially in patients with a history of asthma. And that was a class taught by Rob Evans, Rob Moldwin, and Jennifer Fariella Moldwin. So you're talking about the three best in the world. All right. Deanna said, I just had my, let's see, Hunner's lesions burned off for the second time. The last time I had relief for 6 months. My doctor has not found the underlying cause. What questions should I ask him for follow-up? Do I need his permission to start lactoferrin? Well, it's always good to talk to your doctor about anything you might try. I mean, you can print out the article on our website. You can print out the research study and send it to him and say, how do you feel about me trying this? I've only had one patient who a doctor said not to try it, and this was a patient who had a previous history of a pancreatic problem. And so she was told by her doctor not to do lactoferrin, but she had her other issues that were the problem. So I think you could send it to your doctor and see what your doctor has to say. It's kind of a no-brainer. I mean, if you do the research yourself, start with our article, and then you can start to Google some of the lactoferrin research. It's very, very encouraging, in my opinion. And in terms of underlying cause, we're really doing the viral theory or the broken ligament theory. And so, you know, having a blood test to see if you have active Epstein-Barr would be fascinating, because if you do, then that could be causing your lesions, and they could give you an antiviral. And they can also do a speculum test, very easy vaginal exam, literally take 30 seconds to do it, to see if you might have a broken ligament. That also has been linked with the development of Hunner's lesions. Jenny said, so pelvic floor driven. So if pelvic floor driven, is it nerves causing food sensitivity since not the bladder wall? This part's so confusing. Okay, so Jenny, the problem with tight pelvic floor muscles, the pelvic floor muscles are skeletal muscles, okay? These are muscles that your body uses to move your legs. So these are not passive muscles. These are very active muscles that are involved in how we move. What makes the pelvic floor muscles very unique is that they're the only skeletal muscles that also control major bodily functions. Because for a woman, there's 3 holes in it: a hole for the urethra, a hole for the vagina, and a hole for the rectum. In men, there's 2 holes. The problem here is that if these muscles are tight, they squeeze things. They will squeeze the urethra. They will squeeze the vagina. They will squeeze the rectum, and that's why it's hard to pee. That's why it's hard to have a bowel movement when you're in pelvic floor. It's why intercourse is painful, because the muscles are tight. It's hard to get a penis up the vagina if your muscles are tight. But the other things that tight pelvic floor muscles squeeze are blood vessels and nerves. And so if your bladder is supposed to get 24 units of blood a day and it's only getting 10 because your muscles are so freaking tight, are you going to have a healthy bladder wall if your bladder is only getting half of the nutrition it needs, half of the oxygen it needs? And the answer, of course, is, it's not going to be healthy. It's being deprived. So the presumptive theory here is when you're in a state of ischemia or ischemia, that's basically deprivation of the tissue. The tissue doesn't have good blood supply, and the tissue starts to break down. It's not as healthy as it could be. And so the reason why patients with pelvic floor dysfunction have food sensitivity at first is because their bladder's just starving for oxygen and nutrition. But once you have the physical therapy and you restore proper blood supply, the bladder heals. The bladder should heal and the food sensitivity should improve. It's a hard fake out, because in your brain you're going, I'm food sensitive, it's got to be my bladder. And yet if they look in your bladder and you have a healthy bladder, then we have to look outside at something else that would be causing some of this food sensitivity, like tight pelvic floor muscle. Zara says, I started taking Lyrica pregabalin in the US for about 10 days now, and the pain is reduced a lot. Do you know what this could mean? I'm on the lowest dose. Well, I mean, it's calming nerves down. That's good. You need to do reading about Lyrica, because, as I said earlier in this meeting, Lyrica is hard to get off once you're on it. And if you've been on it for an extended period of time, especially if you've increased your dose higher and higher, it gets harder and harder to wean yourself off of it. And Lyrica is known for causing a discontinuation syndrome. So what does that mean then? It means, at least the way I would interpret that, is what I do with all my meds, and that is I go for the lowest effective dose. So if you're doing the lowest dose and it's benefiting you, that's great. Do you need to go higher where the risk of discontinuation syndrome might be greater? Maybe not. If the low dose is working for you, that's great. But I also think that you need to just have a really good discussion with your doctor about this. And you can Google Lyrica. And the reason why this is important is because I've worked with patients who have gone through Lyrica discontinuation syndrome. And So here, I mean, pregabalin-associated discontinuation syndrome's a case study. Here's one from 2023, delirium, and that's very common. I worked with one patient who had hallucinations for about 6 months after stopping Lyrica. And here, drugs.com, can you stop Lyrica cold turkey? Only in certain circumstances should you stop Lyrica or pregabalin right away. You should stop this medication if you've been directed by your doctor to stop it, or you have a severe life-threatening allergic reaction, or if you've developed angioedema, or you're having trouble breathing, and they want you to call 911. Otherwise, talk to your doctor before you decide to stop taking it. If treatment must be stopped, your doctor will slowly discontinue or taper your medication dose over time to help lower the risk of withdrawal side effects. With many medications, especially those that work in the brain, suddenly stopping the medicine may lead to unpleasant reactions. So with Lyrica, withdrawal side effects can include headaches, upset stomach, diarrhea, trouble sleeping, increased sweating, feeling anxious, and hallucinations are real. I mean, I've literally worked with patients who had that happen. So, it's this is a situation where you have to be very, very informed, and you have to take the lead in decision making here and really ask yourself if this is something you're willing to go through. I have one very, very good friend who's an IC patient, one of the earliest IC patients I ever met. I met her like 30 years ago. And she was on insane levels of antidepressants and other meds. And I just talked with her this week twice. It took her 5 or 6 years to get off of all of them. And she really feels like she was misled by doctors who said this is easy. I mean, it's all right. It's tricky. I mean, I know for me, again, for my body and my drug sensitivity, I know that it's almost impossible for me to increase doses. That I literally start usually with half of the lowest dose. Because I'm just so sensitive. And even with my blood pressure med, we've tried 3 different blood pressure meds for me I was on half of the lowest dose, and my blood pressure has been pretty high because I've been pretty stressed out with cancer and trauma. And so we just went to the normal low dose after like 8 months. And I could feel it. I mean, I definitely could feel that we increased the dose. So, but it's working. Jenny said, my food sensitivity has been bad for 4 years now. I've had pelvic floor therapy, pelvic floor relaxing now since last year, but extremely sensitive. Bladder as of last April looked normal. Can nerves also be irritated by foods, even though the bladder wall's healthy? Yes, honey, absolutely. You have that is the absolute definition of widespread pain, hon. So you're in the central sensitization widespread pain phenotype like I am. So that means the integrity of your bladder wall's fine, just like mine is fine. You and I have uber, uber, uber sensitive nerves. And so we are going to be extremely vulnerable to caffeine. We have to avoid everything that's neurostimulatory, which is going to be caffeine, it's going to be chocolate, things like green tea, black tea, matcha, stuff like that. Um, and what's interesting is it would be interesting to know, like for me, the products that are worse for me with my sensitivity are anything with caffeine, anything. So like I can actually get away with acids because with diluted acids because my bladder wall's fine. It's just the nerves throughout my entire body are sensitive. And so, and you've got nerve burning sensation in your legs and arms. So you probably have small fiber polyneuropathy, just like I do. Are you a redhead? Are you a blonde or a redhead? Because us redheads, no caffeine since your 20s due to anxiety. You strictly follow an IC diet. And oh, girl! Hello, Ginger. Only a ginger can call another ginger a ginger. We're twins. So the challenge with redheads is we have more nerves. We have more nerves. That is. It's what it is. We have more nerves. And so we have 30% more nerves structurally than people who are not redheads. And so we're already born with a more sensitive nervous system because we have more nerves to get triggered. It's much harder to have anesthesia. It's harder to knock us out. Much harder to have dental work. And like my, like I love coffee. I can't touch it. I can't even touch decaf right now without it triggering arrhythmias and tachycardia. I'm just like not allowed. I've had firm lectures from the cardiologist. Never, do not do it. You're too sensitive. So PEA, have you tried the PEA yet? The Piora? I mean, it's been life-changing for me. And the research behind PEA is stunningly successful at calming nerves down. I guess, and the other thing I would want to know, Jenny, is have your muscles responded to therapy, or you bought some? You're going to start it today. Good. Give it a shot. Now, I take mine before I go to bed, and I just take 1 or 2 pills or capsules. But when I first started it, I just did 1 a day for probably a month. And I had it with food. I've never had a side effect from it, ever. I mean, the side effect profile is slim to none. I think I went through about 30 studies, and virtually every study said extremely well tolerated. One reported 1 side effect. And I think maybe in the last 4 years, I think I maybe had 3 patients call who said that they thought that it bothered them a little bit. And ow, sorry, I'm rubbing my incision. Ow, stop it. The great majority seem to do well. The great majority. So, Shemfer says, can you share what you did for your widespread pain? PEA. I did the Piora, palmitoyl ethanolamide. That calmed my skin down massively. And most importantly, you got to listen. The foundation for widespread pain is an injury to the central nervous system. We know that now. The connection, why do some of us develop widespread pain as an adult? What the research shows is for 80% of those children, there is a major physical injury in childhood. For the other 20%, it's a history of abuse or bullying. And I have shared that I grew up in a neighborhood with a kid who became a rapist murderer, and I was one of his earliest victims. I ran to school every day as quick as I could to avoid getting hurt. I ran home as quick as I could. I didn't leave my home without fear for a decade. Think about what that did to my central nervous system. Because, I mean, here's the thing. We're in the old days, I like to say this was mental illness. This is not mental illness. This is how a body adapts to trauma. How did my child's body, my brainstem that has one job to save my life, because cognitively, I did not understand what was happening. I mean, I knew I was being hurt. I knew I was being chased. But as I got older and I started having these issues, vulvodynia, the IBS, the TMJ, the migraines in my 20s, and you guys, listen, I'm a smart cookie. I study extensively. I have a lot of college degrees, and I still didn't understand it. And I still thought it was my fault. And I still thought that I was being punished. I literally went through a period of time where I thought that I was a bad person. And I wasn't a bad person. I was injured badly because of long-term prolonged childhood trauma. And what that injury was that my brain got stuck in fight or flight. That 24 hours a day, 7 days a week, from 4th grade until I was 35, I was in fight or flight every moment of every day. And that causes a ripple effect throughout the entire central nervous system. Fight or flight amplifies pain. And so therapeutically, number one, not your fault. It was never my fault, ever. And the theme that I have in my office is that being the child of an alcoholic, you'd be amazed at the number of patients with widespread pain who grew up in hostile homes with an alcoholic or two. So now when you look at the science and you start reading about what adverse childhood events do to your nervous system and do to your body in general, and how is your body trying to keep you alive? It's trying to keep you alive to prepare you to fight or flee by, taking control of your brain, and that amplifies all the pain. So the tragedy of childhood trauma, of any trauma, it doesn't matter what age you are, it's that your brain remembers it. It becomes part of your personality schema. It's how you look at your life. It's how your brain tries to understand what you go through. I told my therapist, I said that I feel like I will forever be the little redheaded girl running as fast as she could home. That's my dominant memory of childhood. It was running home, crying, and in fear. But see, here's the thing. I'm 64 years old now. That guy is in prison. He's a 3-striker. He'll never get out of prison. And he might even be dead. The DA told me he was dead, actually. What happened to me as a kid will never happen to me again. I will not let it happen. I would never let it happen. I am capable of defending myself. And if you grew up in the home of an alcoholic, I was working with a patient last week or 2 weeks ago, who all of her siblings, all of them, there are like 4 of them, they all have widespread pain. They all live with massive anxiety. They all have variations of IBS and all that sort of stuff. Boys and girls. You know that home was filled with massive trauma that changed their lives forever. And as I went through all this information with her, and we started going through the science, and we started talking about how do we get out of this? Well, the most important thing we have to do is recognize if you're in anxiety every day, you're in fight or flight every day. That is amplifying everything. So we got to get you out of fight or flight. When we get you out of fight or flight, your entire nervous system calms and begins to stabilize. We just didn't know the ripple effect and how this would haunt us for decades. So we now have really good techniques to get you out of fight or flight. It's sensory information. Fight or flight is controlled by the brainstem. This is the most primitive part of your brain. There is no cognition happening here. This part of your brain, it has one job: to save your life. How does it do that? It monitors your sensory input. What do you hear? Is it somebody screaming, or is it your favorite song? What do you see? Is it a fire racing to you, or is it a puppy? What do you smell? Is it a fire, or is it an apple pie cooking? What do you taste, Jane? Does it taste good, or does it taste bad? Your brain stem is your sympathetic nervous system is monitoring your sensory inputs all day, and it's just looking for threats. And when it sees something it doesn't quite understand, it compares it with what you've gone through. Is this good or bad? And if it attaches a negative interpretation to this, like, for example, let give you a good example. So let's say you grew up in the home with a violent alcoholic, but now you're an adult. You're not with your parents anymore. They may be gone, but the smell of alcohol gets you every single time. So you go over to a friend's house, they've got alcohol on your breath, you are triggered big time. Brings it all back because the smell of the alcohol brings it all back. So what we have to do is we can turn that off by giving the brain good sensory information. We can prove to your brain right now that you are completely safe and that there's no reason for you to be in fight or flight. And I can teach you let me just teach you a quick, Lori, hold that question. Hold that question. I'll come back to that. I've got an answer with that. I'm going to teach you a really quick technique. Works every time. It's never not worked. If you were on the phone with me, we would do this. But I'm going to run through it quickly. In real life, you're going to go through it slowly. So let's just take 2 deep breaths real quick. We're going to go in and out. Let's do it again. We're going to go in for 3 and out for 3. Okay. I want you to pick something in your room or your environment or out your window that you like to look at. Something that you enjoy. So I have this in my window. I like glass and I like animals. So I have this in my window to look at. So I'm going to put that back there. Okay. I want you to pick something that you like to look at. And let's just look at it a couple of seconds. Could be a cat, could be a flower, could be a tree, could be at sunset. Let's pick something that you find enjoyable. Okay? Deep breath in and a deep breath out. Okay. Besides my voice, what can you hear right now? Are there any sounds? Can you hear TV on? Do you hear music on? Do you hear the wind? I have a little heater right here that I can hear. Take a moment and just listen. And your brain is processing now. It's like, what is it? What do I hear? What do I hear? Okay. Deep breath in. Deep breath out. Okay, now we're going to do the sense of smell. Take a moment and just smell. Just smell. And it's okay if you don't smell anything. It's fine. But just take a sniff. Can you smell anything? Dinner cooking? Did you already eat dinner? Are there any smells in the room? You're just making your brain identify and play with some smell. So like what do I smell? I smell kind of a slightly hot a lamp here that I have. Okay. Deep breath in, deep breath out. Now we're going to do the sense of taste. Are there any flavors in your mouth? Any flavors? I have a tiny bit of something related to my juice. So any flavors in your mouth? It's okay if there aren't any. Okay, deep breath in, deep breath out. Now I want you to take your hand and I want you to rub it up and down your thigh 10 times. Okay. So we're using the sense of touch. No threat. Kind of felt, I'm wearing a really old soft pair of jeans. Felt good. And you're making your brain look at it. Your brain's firing right now, going, ooh, what is this? Ooh, this is kind of nice. Very different. Okay, deep breath in, deep breath out. Okay, now comes the fun part. But there's one rule for this next part. You may not mention IC at all. IC does not come into this discussion at all when I ask you these questions. Okay. You're welcome, Anne. Okay. If you could look at anything that would put an immediate smile on your face, what would that be? Would it be a sunset? Would it be the ocean? Would it be a waterfall? Would it be a puppy? Would it be a grandchild? What would you just love to look at that would put an immediate smile on your face? What would that be? For me, that would probably be my sister. So I want you to close your eyes and I want you to just take a couple of seconds and visualize. Or a beach in Honolulu called the Kahala Beach, which is a local beach. Tourists don't know about it. And it's just this little tiny sweet beach, big sandy area, and beautiful sunshine, and it's just wonderful. So close your eyes and visualize what you would love to look at. Okay, deep breath in, deep breath out. Okay, what would you love to listen to that would put an immediate smile on your face? Would it be your favorite music? For me, it's Winnie the Pooh doesn't know what to do. Got a honey jaw stuck on his nose. That's my happy song. Or would it be the sound of ocean waves? What would you just love, or a child laughing or a family member laughing? What would you just love to listen to? They would give you a sense of peace and comfort. So close your eyes. And listen to it. I'm going to go back to the beach. I love the sound of ocean waves. Because, you're just away from the stress of the day. Okay, deep breath in. Deep breath out. Okay, so now we're going to do the sense of smell. What could you, and this is an interesting question because it's so interesting that people have never thought of that before. What would you just love to smell that would put you into a happy place? For me, every single time, it's baking cinnamon rolls. Anything hot and cinnamony is my happy place. In fact, I made an apple crisp 2 nights ago. It was wonderful. Lots of cinnamon, hot cinnamon. Would it be roses? Would it be your cat or your dog? I love the way my last cat, I just love her smell. It always made me so happy. Could be your lover. Close your eyes, and I want you to think about a smell that brings you great joy. Pancake syrup. When I was a kid, my pillow smelled like maple syrup. Okay, deep breath in, deep breath out. Now for this next question, no IC diet, none of that. If you could take one bite of anything, much less eat the whole thing, but what would you just love to eat or drink that would put an immediate smile on your face? I love the answers I get from my ICers. I had one client who, man, she described this wedge of fudge cake to perfection. You know, that's what she wanted, just a bite of chocolate fudge cake. For me, it's a hot cinnamon roll, you know, all gooey, hot, melty, yum. What would you just love a taste of? I doesn't. Your bladder's fine. You can eat anything you want in this exercise. Would it be a steak off the grill? Would it be barbecue? Would it be some wine, coffee? You pick it. I want you to close your eyes. And I want you to imagine that you're sitting at your table. You got a friend or a family member at your side, and in front of you is your food or your beverage. And you're going to take a sip. Or for me, I've got my fork, and I'm going to go ahead and I'm going to take a section of my gooey, hot, steamy roll, put it to your mouth, put it in your mouth. Oh, heaven! So good. So good. That is my happy plate. Okay. Deep breath in. Deep breath out. And last but not least, what could you touch that would put an immediate smile on your face? Would it be a cat or a dog in your lap? Would it be warm sand at the beach? Would it be fresh cotton sheets? Would it be your lover? What would you just love to touch that would put an immediate smile on your face? What would that be? I'm going to go with a cat in my lap. So I want you to close your eyes, and I want you to imagine whatever it is that you're touching. Just be there. Just a couple of seconds. She's laying right. I had the tiniest cat, and she could move. I don't know what she did in the middle of the night, but she could move my body however she wanted me to move my body. Every morning I woke up with her asleep right here. It's crazy. But there's a reason why having pets lowers your blood pressure. It feels good. Okay, deep breath in. And a deep breath out. How do you feel? You have a smile on your face? Odds are you do. Because that exercise turns off fight or flight. We have just proven to your brain you are completely safe at this moment. And it will stay off for hours and hours and hours. This is a great exercise to do every single day. I do it almost every day because I do it with patients almost every day. And if I'm struggling with anything, I do it. And I even did it with my dad. And it was so fascinating to hear his answers. Like, what's your favorite thing to smell? And what's your favorite thing to eat? And it's great to do with young kids. If you have a kid who's having a meltdown and you just are just having trouble, just go sit on the couch with them and say, honey, what is your favorite thing to eat? What do you love to smell? And it's amazing when you ground yourself in sensory input, it calms your central nervous system down. Now, there are a lot of other techniques that do this too. There's one called EMDR, there's one called tapping. I'm doing a combination of EMDR and tapping right now with one therapist, and I just love it. I just love it. And this is, again, we've taken this out of the realm of mental illness, focusing instead on how do we heal an injured nervous system? How do we retrain an injured nervous system that's been stuck in fight or flight for a long time? And it works. And some of these techniques have been tested with guys coming back from war and women coming back from war. They work. So nobody's saying you're mentally ill. What everybody's saying is, hey, honey, you got hurt big time. Now let's see what we can do to heal that nervous system structurally and physically. And one of the ways we do that is with exercises like this, which bring that brain out of fight or flight, and it works beautifully. I have a video. There's another piece to this, because the question is how long is it going to stay off? And the answer is hours. It'll stay off for hours. But as soon as you have a negative thought, you're going to turn it right back on. And that's the conundrum here, is that when you're in fight or flight, you're anxious. And that's when your brain starts to go, well, I need to keep you home. The way I'm going to keep you home is I'm going to scare you. Hey, Jill, you want to go to the movies? No. Won't be able to get to the bathroom. I'll have a flare. You want to go out to a restaurant? No. I won't find any food I can eat. Hey, you want to go take a drive up to Tahoe? No, it'll hurt. People with anxiety say no to everything. I said no to everything for years, reflexively. Like literally, they wouldn't even be done with the invitation. I immediately say no. And it's like, wait, I want to do all of that. Why does my brain say no? That's fight or flight. That's your brain going, something happened, and it's trying to keep you safe. It's trying to keep you home. But the thing is you are safe, and that trauma doesn't have to limit you now. You literally need to go do those things. So I took an anxiety management class that really changed my life, and it was created by an orthopedic surgeon with anxiety, and so. The first cool thing that happened was literally in the first 5 minutes, because up to the point that I took that class, and remember guys, I had a master's degree in psychology. I was going on for my PhD, and I was a straight A student, and I could not control my anxiety until I went to this class. Okay. The first big lesson happened in the first 5 minutes when we just introduced ourselves. And I always thought that I was the walking, talking role model for anxiety, for being screwed up. Like I thought somebody could just look at me and see how messed up I was on the inside. Until I met other patients, and it was like, oh, wait a second, that happened to you too? Oh, you were hurt too? You too? And I saw immediately that all of my fellow students were trauma victims like I was, all of them. Up to that point, I thought that I was abnormal. After that point, I recognized very quickly that I was just an entirely normal person, just like everybody else. I'd just been traumatized severely. That took a lot of the shame away and a lot of the blame away. Just meeting other patients was so cool. And then the instructor was like, he said, how many of you say no to everything? Yeah, we all look at each other. Oh, you too? Yeah. How many of you are super sensitive to chemicals? We all raise our hand. Oh, you too? Yeah, me too. How many of you have problems taking medications? You do. Oh, yeah, me too. How many of you are chemically sensitive? Like you can't have strong candles in your home? Everybody. Oh, wow. Okay, everybody. And then he explained that a injured nervous system becomes a very, very sensitive nervous system. A nerve that's injured is easier to turn on. It's more sensitive. It takes less stimulation to get that nerve to fire. And he said, you know how sensitive you are to all the chemicals on the outside? You are also sensitive to chemicals on the inside. And he said, right now, every single one of you are overdosing on adrenaline. You have so much adrenaline through your body. That's what's driving all of this. Adrenaline is the chemical mediator of fight or flight. That's how your body prepares you to run or flee or fight. And the problem is that every single time you have a negative thought, you get a jolt of adrenaline because you scare your brain. And you don't just have one negative thought a day, honey, you got 200 negative thoughts a day. You can't kid a kidder. I've been there. I have been there. That's hundreds of shots of adrenaline circulating through your bloodstream at any given time. And it's the adrenaline that's making your heart race. It's the adrenaline that's making you nauseous. It's the adrenaline that's driving all the negative thoughts. You get stuck in this vicious cycle of negative thought, adrenaline, more negative thoughts, more adrenaline, more negative thoughts, more adrenaline. Then before you know it, you're just stuck. You're just stuck up here. And it's amazing how the negativity becomes very personal because you just don't understand what's happening. You don't understand this is a trauma response. So the instructor's like, okay, you want to know how to turn this off? We got to lose the adrenaline. If we can get you, reduce the levels of adrenaline in your bloodstream, you're going to feel a lot better. And we're like, okay, how do you do it? He goes, easy, oxygen. Oxygen turns off adrenaline. I'm like, okay. And he taught us a 3-step technique that I have used for the last 30 years. That whenever you have a negative thought, the very first thing you do is visualize a stop sign, stop. Then you take a single deep breath in for 3 and out for 3. And you guys, whenever I'm looking over here, I'm looking at YouTube. And whenever I'm looking here, I'm looking at Facebook. So I'm looking at 2 different streams if you're wondering why I keep looking over there or here. Stop sign, deep breath. And then the 3rd step is you have to remind yourself it's just a thought. It has no freaking power. It's just your brain trying to keep you home and safe. It's the fight or flight response. Stop sign, deep breath, minimize the thought. And the instructor said, okay, for the next week, I want you to tune in. Every single time you have a negative thought, rather than feeding the adrenaline, we're going to turn it off. I want you to use that technique. I'm like, okay. I understand the science of it. I'm in. I'm sick of living this way. Of course, I had my first negative thought walking out of the room, which is, oh my God, this is stupid. It'll never work. But I did it. I recognized that as a negative thought. That first day, I did it at least 100 times. And honestly, I was stunned. I had been so used to the negative, scary thoughts. When I actually paid, I just kind of tuned them out, but they were always there. They were always there. And a lot of them were about me. Like, oh my God, Jill, you're so pathetic. What's wrong with you? You're such an embarrassment. Those were the types of, my self-esteem was in the toilet back then. So I just didn't understand anything. Okay, so I did it at least 100 times the first day. Second day, 50 times. Third day, 20 times. 5 days later, I only had it to do it once. And for the first time, I took that class when I was 35. For the first time since 4th grade, when I was first attacked, I was calm and peace. And you know what? It was life-changing for me. And I came to realize that it's multiple negative thoughts in a row that are the problem. So, I was really good. I went from having hundreds a day to maybe having one negative thought a week, probably for 25 years. And of course, you can see I live in a very happy home. I got things around me that make me happy. I don't live in a dark room. All the drapes are open. I've got things that inspire me, like love signs and hope signs and things like that. I'm very purposeful in how I live my life. I want it to be, I need things around me that make me smile. But then COVID hit. And then I lost my parents. Then I got cancer. Then I almost died. And let me tell you, I definitely have more anxiety now. But I have a system that works. When I catch myself having I will often let one negative thought go. And ironically, the one day I will have like one negative thought a day, usually. And it's usually about an earthquake or a fire. It's so weird. And I will let that fly. If I have 2 negative thoughts in a row, stop sign, deep breath, minimize the thought, man, I'm on it. And if I have 3 in a row, I do it twice. And I have caught myself having multiple negative thoughts in a row, but I never let it get out of control. Like, I don't think I've had a negative thought today. Have I? No, I haven't. I had a couple yesterday driving up to my sister. I do it. Stop sign, deep breath, minimize the thought. I never let the adrenaline build up. The hard part is that, your brain remembers the trauma. And that's why therapy is good, because you have to you got to get in there and recognize it and recognize what triggers you so that you can let that go. And that's why I'm back in therapy again, because I just kind of want to be released now. So anyway, that's my technique. That's my big technique for widespread pain. It's not a treatment. It's not a medication. It's recognizing the effect of trauma on your brain and reteaching your brain how to be calm again. Okay? All right. So Lori said, medicine sensitivity. Thoughts on estradiol filler ingredients worsening IC? I ceased using it December, opting to use and apply B-Magic. Much improvement. So yes, estradiol, and especially brand names like Premarin, extremely well known to have fillers that are irritating. And this is why we go to a compounded estrogen cream at a pharmacy where they use propylene glycol-free or preservative-free fillers. So I had the same problem with estradiol Premarin, but I switched to compounded and I was fine. The problem with what you're doing is that that skin needs estrogen to produce mucus. V-Magic is temporary. And underneath the V-Magic, your skin is going to shrivel and it's going to get dry again. You're not giving it the ingredient it needs to produce mucus. So I really would not give up on estrogen. I think you need to go to like the Women's International Pharmacy. They just changed their name. It's a different name, but it's women'sinternational.com. And a good compounding pharmacy will have several bases, and they will send you little samples. They can put it in coconut oil. They can put it in olive oil. They can put it in all sorts of stuff. And then also you got to remember too, like if you're super, let's say you got a compounded cream, no preservatives in it. There's nothing in it that should irritate you at all. but you put it on and it burns. What does that mean? What that means is your skin is hella dry. It means that your skin doesn't have mucus, and anything you put on it is going to cause a burning sensation. But every time you give that skin estrogen, it absorbs the estrogen and starts to produce mucus. It's like putting a raisin in a glass of water. The raisin absorbs the water and plumps up. That's exactly what these skin cells do when you give them estrogen. And so it's quite normal for patients to experience some discomfort for a couple of weeks. But then it should get better as your skin gets better. The exception to that rule is if every single time you use the estrogen, you burn immediately, then we have to assume also that there might be something in the form of estrogen that you're buying that might be a problem. Or you can switch over to the estrogen tablet, which isn't a cream base. So putting that little estrogen tablet up in your vagina might be a way of around this too. The estrogen cream's better because you can put it in more places. But if that doesn't work for you, you can do the Vagifem tablet instead. Anne says, thank you for all you do for us. Love the IC Network. So much helpful info. Yes, we're not alone. Reading pelvic pain from the ICN. So many questions answered. Diagnosed in 2008. Enjoy his glorious day. Thank you, Anne, if you're still here. Thank you so much, honey. Shemp says, this makes so much sense. I can relate. Thank you so much for sharing your story. Good. Excellent. Shemp says she feels better. Yeah. Yes. All right, let's come back to Facebook here. Jenny says, I'm probably pelvic floor and central nervous system, but both bothering my bladder. I think the Kegels I've been doing are making the pelvic floor mad. Yeah, you're not supposed to do Kegels if you have tight muscles. If Kegels hurt, that's a problem. Susan says, I believe I may have two types of IC. Wall-driven 71-year-old. You had a hysterectomy at 45. Now you're in pain with a dry vagina. My vagina is a little dry too, to be honest. Using estrogen cream helps you, but you're fearful because you have a high risk of breast cancer. Okay. Pain with sitting too long, better with standing and long walks. Severe adhesions from 3 pelvic surgeries. Help your thought. Okay, so Susan, concept number 1 here, you nailed, and that is you had a hysterectomy at the age of 45. I'd like to know why you had the hysterectomy. Why did they choose to do a hysterectomy back then? Was it because you had fibroid tumors or endometriosis? If it was a total hysterectomy, girl, you have been in estrogen atrophy for 30 years. And that is absolutely going to affect your skin and cause a lot of dryness. We call that the genitourinary syndrome of menopause. Now, speaking as a fellow breast cancer patient, because I was diagnosed with breast cancer this year too, I'm not high risk though, you're high risk. What the research shows is that topical estrogen is considered much safer than oral estrogen. And so I'm using topical estrogen. But I was at a meeting, and I think that this would be important for you. What meeting was it? It was an online meeting of IC experts like 3 years ago. And a doctor said that one way of reducing further risk is to use it externally rather than internally. That the deeper you put it in your vagina, the more of it that might be absorbed. Whereas if you put it on the external skin on the outside, she said that that would even minimize systemic absorption even more. I will tell you that I generally only use mine externally at my urethra and on my labia, but I'm now entering a phase where I can feel dry vagina a little bit more now. And so if I'm doing it internally, I might do it once a month, but I'm going to use it externally couple of times a week. So you could talk to your doctor and see what your doctor says about doing a strategy like that. Okay. Now, the pain with sitting and better with standing and long walks. I guess I have two questions for you. Where is the pain when you sit down? If the pain is on your labia in your crotch by your urethra, concept number one might just be that your skin is very dry on the outside. And so, in addition to using that little bit of topical estrogen, you might want to try V Magic. Here, it's right here. Vulva Balm. Vulva Balm. This is an organic avocado, olive, sea buckthorn oil that very closely mimics your own natural mucus. A lot of people don't understand that your mucosal lining is actually fatty. It's an oil base. Here it is, right here. And it has a really very, very light consistency. It's very, very close to your own natural mucus. And so this is a go-to for any women who struggle with dryness down there. It's better than coconut oil. You can also do an organic, extra virgin coconut oil. The problem with coconut oil is it soaks through everything, and you'll have oil spots on your underwear and oil spots on the back of your pants. This is better. It's lighter. So this is called Medicine Mama's Vulva Balm. It used to be called V Magic. But the other thing that we would think about, Susan, I mean, you have adhesions from 3 pelvic surgeries. And anytime somebody has pain when you sit down that gets better when you stand up, we're really talking about body mechanics. We're talking about muscles and nerves. That changing your body position, it's somehow causing a muscle to irritate a nerve or squeeze a nerve. So pain when you sit down that gets better when you stand up is actually a sign of pudendal neuralgia, which means you have a muscle squeezing or you have something squeezing the nerve in that specific position. Another sign is pins and needles, areas of numbness, feeling like you're being poked by a pin, or even persistent genital arousal disorder where you feel like this weird, incredibly disgusting, awful, annoying arousal sensation in the middle of the night while you're in the middle of the day while you're washing your dishes. Like there's no sex in your mind and yet you get this weird feeling. And that's just a muscle squeezing a nerve. So, Susan, given the fact that you've had 3 surgeries and you have adhesions, are you doing physical therapy? Are you working with a pelvic floor physical therapist? That's a big, giant piece here for people who have pain when they sit down that gets better when they stand up. Also, and I'm one of these patients too, I sit on this cushion. This is our waffle cushion. That's great. I sit on that for pain in my glute muscles if I sit too long. But if I'm having pain in my crotch and my urethra, we have a different cushion. This is the Sun Cloud travel cushion, and it has a groove down the middle. So each butt cheek is supported, but nothing is pushing up against your crotch, your urethra, your rectum, your vulva, your penis, your prostate. So when you have pudendal neuralgia, you have to be you really got to be on top of what you're sitting on. We don't want you sitting on anything hard or sitting on a bike seat or a horse saddle, things like that. You got to be really careful with that. So Susan, I don't know if you're still here or not. I think you probably are. Feel free to call me next week on Tuesday or probably Wednesday would probably be better. Hold on, let me just see what my schedule is on Tuesday. I would try mid to late afternoon. And then Wednesday morning, but I'll be out in the afternoon on Wednesday. But I'll be here Thursday and Friday, knock on wood. Gratitude, my friends. Gratitude for every day. Lori says, see my guy next month. We'll see compounded, was using the brand for 3 years. Yeah, man, there have been books written about, there's a whole chapter about Premarin and the issues of Premarin in a book I read years ago. It's a red and purple book. What was the name of it? It's out in storage. Well, anyway. All right, guys. Well, listen, we've been going for 3 hours. Pretty good meeting, if you ask me, even if I was a little scattered when we started. So I think, Lori, gratitude to you too. Thank you, Jenny. Thank you so much. So if you find these meetings helpful, come on over to the IC Network and join our mailing list. It's free for our newsletter, or you can become a member and get our magazine, which is where I do my best work. And I would really appreciate it if y'all could go over to our YouTube channel, where I keep all of our videos and stuff, and copies of the live streams. And our master classes are all over on our YouTube channel, which is youtube.com/ICN Jill. Like IC Network, ICN Jill, Jill. And if you could subscribe to that channel, that'd be great. I need 10,000 subscribers for me to do more. And I think I've got 7,500. I want more. I'm greedy. I want more because I want to do more. Anyway, all right, guys. I think we're done for the day. Be well. Have a wonderful evening. We'll see you next week. And next weekend, I'll show you the next magazine. All right? And I'm sure we'll come up with something to talk about. I'm going to say goodbye to Facebook. Actually, I'm going to say goodbye to YouTube first. Bye, guys.